is minimally invasive head and neck surgery. Module 2, that is robotic surgery of head and neck. I'll be introducing the speakers for evening session today, starting with Dr. Scott Magnuson, who is a board certified otorhinolaryngologist, head and neck surgeon. He possesses advanced training in robotics assisted surgery and is a leading authority on transoral robotic surgery. He is also the co-medical director at Advent Health Research Institute, Orlando, Florida. Next, we have Dr. Rajesh H. He is the chief anesthetist at HCG Cancer Center. He is the fellowship director for Onco-Anesthesia Training Program. Next, we have Dr. Surendra Tabas, who is the director and HOD of Surgical Oncology and Robotic Surgery Department at BL Kapoor Hospital, Delhi. The next speaker is Dr. Eniana Ofo, who is the consultant ENT, head and neck, and robotic surgeon at St. George's and Kingston Hospitals and honorary senior lecturer at St. George's University of London Medical School. The next speaker is Dr. John De Almeida, who is an associate professor of Department of Otolaryngology and Head and Neck Surgery at University of Toronto. He also practices at Department of Surgical Oncology, Princess Margaret Cancer Center, Siani Health System. We have Dr. Uma Maheshwar Duburi, who is an associate professor in the Department of ENT Head and Neck Surgery Division, University of Pittsburgh. He serves as the Director of Robotic Surgery at Division of Head and Neck Surgical Surgery and is the current Director of Center for Advanced Robotics Training at the University of Pittsburgh Medical Center. We also have Dr. Mudit Agarwal, who is a unit head and senior consultant at Rajiv Gandhi Cancer Institute of Delhi. So for the evening session, the moderator is Dr. S. Vidyadharan, who is a senior consultant, head and neck surgical oncologist at Apollo Proton Cancer Center, Chennai. He also serves as adjunct faculty in head and neck surgical oncology at Amrita Institute of Medical Sciences, Kochi. Thank you so much for this opportunity. Now I hand over the screen to Dr. S. Vidyadharan for further needful. Over to you, sir.
Thank you, Jyoshna. Good evening, everyone. We will now start with all the topics for today's session. With any procedure, any surgical procedure, the operation theater personnel, the setup is always very, very important because it helps the smooth flow of the surgery. And to talk about robotic instrumentation, personnel, operating room setup in transoral robotic surgery, there's no one better than Dr. Scott Magnuson to give this talk. So, Dr. Magnuson, the floor is yours, basically, to start.
Thank you. And hello, everyone. Thank you to the organization committee for including me in this meeting. I'm going to go ahead and share my screen here. Can you see the screen?
Yes, we can see the screen.
I'm going to minimize the photos, the pictures in the room so I can see. Okay. So again, thank you to the group in India for organizing this meeting. I think it's a fantastic platform. I was sharing before we started with a few people of how beneficial the web has been in terms of us participating in these conversations. The thing I miss the most is the personal interaction with everybody, the hellos and the sharing of a drink. But of course, we can still learn during this time and still communicate some of our information to each other and hopefully continue with the education process that we are all dedicated in participating with. So as it was said, my introduction this morning is to the TORS setup. It's about how to set up properly, get in the right position, because if your setup is not correct, if your setup is off a bit, you're going to have a very difficult time performing the operation that you intend to perform on a patient. So let's take a few minutes, 15 minutes, we'll allow for some questions to talk about this setup. So as my outline here, this is representing the Advent Health Nicholson Center where we work, and we have all of our training facilities in this building. I'm going to introduce first some of the previous reports in the beginning of TORS. remind everybody how we got started with tours. I'll discuss shortly about patient selection. We'll discuss setup, and then we'll have some closing remarks and conversation. So the history of tours really falls back on these 4 institutions. It began with University of Pennsylvania with Bert O'Malley and Greg Weinstein. They had the idea of taking an instrument, at that time a very bulky standard platform with huge arms, and taking 3 of the 4 arms and beginning the first single site natural orifice operation by placing 3 arms, 1 camera, 2 instruments into the patient's mouth. There were 3 institutions that picked up on this procedure to help develop the procedure. That was the Mayo Clinic, University of Alabama, Birmingham, where I was located at that time, and also, of course, University of Pennsylvania. The 3 of us collected data on patients prospectively, and the data that we collected had to do mostly with feasibility and safety of the operation. Chris Holsinger from the MD Anderson Cancer Center at that time, he's now at Stanford, was our data safety monitor, and he kept our data to make sure that we were using clean data and appropriate data. And this was finally submitted to the United States Food and Drug Administration in 2007. And in December of 2007, TORS was approved in the United States for T1 and T2 oropharynx cancers, as well as benign conditions of the oropharynx. Since that time, even though the USDA has, the United States Food and Drug Administration, FDA, has only approved a limited number of cases, there has been an explosion of the use of this technology in the head and neck, where I think I've performed nearly all of these procedures. Maybe a couple of I haven't performed using the robot, but you can see there's an unlimited number of procedures that we can do, and the applications continue to grow. I think if we looked at this list today, I may be missing a couple of procedures, but the applications are pretty significant in the head and neck area. But getting back to starting, patient selection is the primary key in having a successful program, especially for new surgeons. My partner, Bruce Hoey, he's a very famous transoral laser micro TLM surgeon, and he has a list of 10 T's that he has in terms of patient selection. Some of these here are tumor size and other things relating to the teeth, for example. And so if you're just starting out and you want to have a successful program, you have to be very selective in the patients you choose. You do not want to choose patients with larger tumor sizes, difficult mouth openings, etc. This patient demonstrated here would be a very difficult patient to operate on. You see, he has a lot of dental work with the upper teeth, a very large tongue. The circumference of his neck is quite wide. If you had a lateral profile, you would see that his chin, neck, and chest are all basically in the same plane. And I think it's really important to understand that there's an ease of dissection by tumor site, so that the more distal you are in the aerodigestive tract, the more difficult it is to perform the operation. So a tonsil is going to be easier than the other sites listed: base of tongue, supraglottis, larynx, and piriform sinus. And the other thing I'll state is the difference in difficulty between tonsil and the following 4 is the most significant difficult step. The tonsil is pretty easy exposure, but as you go from a tonsil to a tongue base, your difficulty increases significantly. The difference then between tongue base, supraglottis, and even piriform sinus is minimal. There is some increasing difficulty as you become more distal, but the differences are minimal compared to tonsil. So if you're just starting out, I would recommend become very facile in performing lateral oropharyngectomies, because in that case, your exposure is the easiest. You have good patient selection, and you'll see in a second in terms of instrument robotic arm docking and placement, the differences are going to be easier for you because of just the way the arms dock. So consider this as you're moving through your sites. Before you go on to piriform sinus, make sure you're facile with tonsil and even tongue base before you go on to those more difficult areas. So a room arrangement is set up like this. What we've done is, and I'll use my cursor, the patient is placed 180 degrees away from the anesthesiologist. That is, we need a full 270 degree access to the patient around the patient's head. And so we take the bed and we turn it, and you want to make sure that you have a long intubation circuit to the anesthesiologist ventilation cart, because you want to have the flexibility of moving this bed even away from, so that you away from the anesthesiologist, so you can bring in the patient side cart. Now you notice here the patient side cart is brought in from the side. It's either brought in from the left or from the right side. And in doing so, it takes the patient cart away from this head so that you have enough space for an assistant here at the head and also a nurse here at the side of the head. The surgeon, of course, is remote at the surgeon console, and the placement of this console is really dependent upon the size of the room. There is no perfect placement of this console as it relates to this. The most important aspect regarding the console is that you have easy access to the patient. You don't have to have direct access. It just has to be easy access. So you can access the patient within, I would say, 5 to 10 seconds of moving over to the patient's side. You're going to have a vision cart that is placed so that both a nurse and maybe another vision cart you'll see, as I have in a picture in the operating room, where the assistant can be looking here, the nurse can be looking here. On the back table, you have all your robotic instruments. I typically use only 2 instruments, that is a Maryland dissector and a monopolar spatula tip cautery, monopolar cautery. I found that the use of other graspy types of instruments may be helpful, but if we want to try to reduce the cost and limit the number of instruments we use, I found that a Maryland dissector can be used, I would say, every time. Suspension and exposure. I like to suspend on a suspension arm that is connected to the patient's bedside, so that as the bed raises or lowers, whatever is best for the position, the height of the table, you don't have to readjust a Mayo stand that may be crossing the chest. So we connect directly to the side of the bed, and this is a Karl Storz suspension arm here. It connects to the laryngoscope, and in this case, the mouth gag we're using is the FK retractor. It's probably the most commonly used mouth gag, but there are other types of mouth gags. There's another one made in the United States from COMeD Robotics called a flex retractor. And then there's a retractor out of the UK called the Lars. And I know in Asia, you also have other retractors that are available there. But in the United States, we only have 2 retractors that are available. We have this retractor and we have the flex retractor. Now, in some cases, especially the oral pharynx, it's not necessary to use these advanced retractors. You can use simply a Crowe-Davis or a Dingman retractor. That exposes the oral pharynx very nicely, and you don't need to have this very expensive piece of equipment in order to get the exposure. For docking, there's a triangulation of the instrumentation as you reach the patient. Now, I was just talking before we came on. I had a webinar last Monday. It was a live webinar just going directly over docking. If you weren't able to watch that, send me an email, and that recording is available on the internet. I can give you the secure website IP address to watch that recording. It's an hour long. It's pretty simple. And we go over just docking, and I use a cadaver model with docking the robot. But in this case, this would be a docking setup for the oral pharynx. And so the triangulation is that you have your camera in the center, and then along the sides, you're going to have your 2 instruments, and they're coming in a triangle type pattern. Now, the triangle can be 2-dimensional, and you'll see that in a second, or this triangulation can be 3-dimensional. And let me explain what I'm talking about here. So these 6 pictures are arranged in columns. And so the first column, these 2 are together. The second column, these 2 are together. And the third column, these are together. And so we have 2 sets of triangulation. You have your triangulation looking at from the patient's head towards the feet, where your instruments are coming in at an angle and your camera's in the middle. And then you have your triangulation that it relates in a 3-dimensional plane. So here there's very little, almost all of these are in the same plane, but in a 3-dimensional plane, you also have a triangulation. And then we explain the differences between these 3 setups. It represents how far you have to go in the aerodigestive tract. So if we are up in the oral pharynx and we're dissecting in the tonsil, this is going to be the setup that you're going to have. You're going to have it so that the arms are coming You have wide space between the arms and the camera, and they're all nearly in the same plane. There's very little difference in the three-dimensional triangulation. They're relatively all in the same plane. But as we go to the tongue base, we have to lower these working instruments so that the angle that you're coming at the tongue base is more horizontal. If we take our camera and we do the same thing and we put our camera down in more horizontal plane, you notice there's less space now between these two instruments than you had when you were more proximal in the aerodigestive tract. So because there is less space between these two instruments, I changed this camera to a 30-degree upward facing camera. So now we have a nearly vertical camera with a 30-degree angle looking upward into the distal pharynx. So again, my working instruments, the arms come closer together and they become more horizontal in nature because of the angle that you have to go towards the tongue base. And this is even more pronounced if we get to the supraglottic larynx. The instruments now are quite horizontal because of the angle going directly into the distal pharynx, into the supraglottic larynx. My camera remains in the same position. It remains in a more vertical orientation, directly in the center. And the benefit of this is you see now between these two instruments, there is almost no space between these two instruments for a camera to sit. This helps reduce collisions between the instruments. And as you become in a more tight space, a more narrow space, your instruments are closer together and the difficulty with dissection is pronounced because of the collisions that you have between the instruments. Now I'm going to take a second on this next slide to show when you are set up in a position like this, you really have to be working with what I call robotic dissection technique and not laparoscopic dissection technique. And let me explain the difference between the two techniques of dissection. So in this case, the first row represents laparoscopic dissection technique, and the second row represents robotic dissection technique. And so I have simply drawn an outline of a tonsil, and you see the instrument here is moving nearly as a straight stick. There's perfect access to that spot right there as the straight stick moves. And you see at the patient bedside, the instrument is moving and there's plenty of room in this space that we have. In this line, in robotic dissection technique, it's a different type of dissection. You see the black part of the shaft is more still, and I'm rolling the tip of the instrument with my finger. We have to take advantage of this instrument of having articulation at the end. So I'm rolling just the tip. Look at the difference between these two. At the patient side, this instrument arm is barely moving compared to this. The space of this that's covering is much greater than the space traveled by this instrument. How do we perform robotic dissection compared to laparoscopic dissection? The key is in the forearm and the wrist. So the black portion of the instrument arm represents our forearm. This silver part, the snake part of the instrument, is represented by our hand and our fingers. So if my forearm or wrist, you see here, is moving, this whole shaft is moving. But if I keep my forearm and my wrist still, and I'm only moving my fingers, my hands, and I'm rolling that tip, then the forearm, then the black component of the instrument, the straight stick component of the instrument, is very quiet. It travels very little at the patient's side. Now, in this case, it doesn't matter which technique you're using. There's plenty of space. There's no collision. On the outside, you may have to consider a patient's anatomy on the inside. There could be teeth sitting right here where they are being hit by the instrument. You want to be careful of that. So you have to stick with the robotic technique of dissection. But where this is critical in terms of the differences in the dissection technique, and I'll go back to the previous slide, is when you are sitting in the base of tongue or the supraglottic larynx, and you have instruments that are so close together, they cannot travel as much space outside of the patient as you can here without colliding. And if you have instrument collisions here, it will block the instrument from working correctly, and you have to readjust frequently, limiting your operation. So Keep that in mind. Practice this robotic dissection technique and try to avoid using a laparoscopic dissection technique. The assistant is going to sit at the patient's head. The area at the patient's head is clear. Now this is different. Of course, I'm talking about this is an SI platform. The XI platform doesn't come in at an angle, it comes in at 90 degrees, but also the arms come above the patient's head and there's opening here. The single port platform, which I also use, is quite different. It actually comes in at the patient's head, so there's less space and the assistant has to move off to the side a bit in order to access the oropharynx. But you see, they are working directly off of monitor in this case. Typically, the monitor is a 2D monitor, but it is possible to have a three-dimensional monitor in the room so that the bedside assistant has depth of perception. So I'll take a few minutes to talk about the learning curve, and then I'll leave it for some questions. So the learning curve is not just based on your ability to perform or learn an operation, but you have to take into consideration these other factors of your learning. Team, how facile and experienced is your team? Your patient population, it varies from area to area, country to country. The frequency of cases, I think, is the most important component, because it's not just the number of cases performed, but it's how quickly you get to a total number of cases. So in this case, this was my case frequency from my first case in March of 2007 until 2011. This represented 160 cases. The important thing is you see my case frequency, even though our numbers are quite low compared to other specialties, was slowly increasing over time. And I think that's important to maintain a proper learning curve. If this case frequency is flat or even worse, is decreasing over time, you'll get to a point where you're frustrated and you what I say, stall in your procedures and maybe even stop altogether. So you want to work and be consistent with keeping your case frequency increasing over time. At some point you'll plateau, but at the beginning you want to have your case frequency increasing. And what I saw in my operative times, yours will be different. This again was at a time where we were developing the procedure, so we were having long operative times. But at 40 cases, I reduced my operative time by 50%. And that just out past 100 cases, my operative time has basically flattened to approximately 1 hour operation for a TORS procedure. So I'll stop here. I'll take some questions. I do want to give a few advertisements. Once the world is open to travel, here are some opportunities for some training at our facility with me. I have two types of training programs. I have an advanced course for those who are experienced already in TORS, and I have a basic course for those who are new in TORS. And these are the dates. You can contact me, or you can go to our website at nicholsoncenter.com/calendar, and you can see these training courses. The other course is sometimes there are some head and neck surgeons who are also interested in obstructive sleep apnea. Claudio Vicini is a wonderful friend of mine. He, Filippo Montevecchi, and Julia Crawford from Sydney. We are organizing the 8th annual, so this will be the 8th year that we do this course. It's a hands-on workshop in Orlando, Florida, and it's in the end of February, beginning March of 2021. We hope that the pandemic will have passed by that time and opportunities will come where you can come and even operate on cadavers with some hands-on dissection. So thank you for your attention. I will, there's my email address. If you're interested, send me an email. Happy to share with anybody any information or help. And I'm going to stop sharing my screen. Let's see. So I can see the group.
Thank you,
Here we
Dr. Yeah. Thank you, Dr. Magnuson. That was a fabulous talk. It was short, and you just highlighted on the most important points. There are a couple of questions, and the first one is by Dr. Dabas. He says, the Intuitive company is phasing out the SI system. What will be your favorite tool, XI or single port after this, Scott?
Yes, Surinder, thanks. And good to speak with you through the internet. So yes, the SI system is being phased out. The XI system is an excellent system. There is one advantage with the XI system, and that is the camera. The camera is superior to the SI system. And it's really disappointing to be using the XI and then go to the SI and not have the clarity of vision with the SI. However, the SI has the advantage not of the size of the instrument. I don't think that's as important with the 5mm versus the 8mm on the XI, but the 5mm instrument articulation is the snake-like, and I really like the snake-like articulation at the tip, where on the 8mm instruments you have the clivus joint, and the joint goes very differently than the snake-like joint. You can operate with that, but I do find a learning curve issue with that in terms of especially seeing the tip of the monopolar cautery. Sometimes the tip is difficult to see, and I think it's important and critical to always see that tip. Moving on to the single port, I've done quite a number of operations using the single port, and the single port has a third type of joint at the end that's called a joggle joint, and they have two joints on the end of the single port. And so there's another learning curve in how to dissect using two joints at the end versus one joint as we have with the XI or a snake joint on the SI. So what is my favorite? I don't have a favorite. I'm fortunate that I can use any platform currently, and when they phase out the SI, I'll just have two platforms. My hope is that 5mm snake-like instruments are designed for the XI system. That would be ideal and very helpful, I think, in the head and neck.
Thank you. Following up on this question, I just have one question. With regard to the robotic and the laparoscopic dissection techniques, does it differ between the SI and the XI? Because you're telling me the tip would block your view sometimes, or you would not see the view.
It's a little different, but it's not significantly different. So with the SI system, you're moving the whole snake, and you're trying to keep your forearm still. But with the XI system, you can still keep your forearm still and move the end of the instrument like this. You really have to be careful and make sure that you're using your fingers a lot. That's critical, where your forearm is held still and just your fingers are moving. If you noticed in that video, my fingers were outside of the straps, the stirrups. That allows me to move my hands around. You can still grip the master control without putting your fingers in those straps. And that allows for me to do more finger movement than it does if my fingers were stuck in there and I had to move my whole arm this way.
Easier maneuverability. Okay, the next question is, in the SI system, how essential is it to maintain the sweet spot while docking? Often when docking, it may not be possible to keep maintaining that sweet spot because it keeps going in and out.
The sweet spot is somewhat helpful for tours, but it's not critical. And the primary sweet spot difficulty is with the camera. Many times the camera might be outside of the sweet spot, and the joint of the camera often collides with one of your instruments from the side because those two joints are coming close together. What I do is I move that joint from the camera regardless of the sweet spot. I move the joint away from the other instrument, and I just take the camera, because now it's oriented on an angle, and you can just take the camera itself and roll it back to being straight. And that allows for the joint to be moved away, and then the other instrument can come in from the side, and the two joints have space between them. So I think what is more important is that last, I'll call it the elbow joint of the arms, that they have space between them. Not so much was it at the top on the blue line that shows the sweet spot, not so much there, but the elbows have to be spaced far enough where they can move and have some space.
The triangulation, yeah. The next question is by Dr. Dixit. He says, any difference with the operator time between SP, X, or XI? I think he means the setup time, but any difference in the operator time between these models?
Well, the setup time is longest for the SI because the instrument arms are larger, they're more bulky, and they're coming off a center column. Where the XI, they're coming off a boom that's across the top, and the instruments are much more thin. The arms, I mean, are much more thin, and they can be placed in with a little bit quicker speed. The single port robot, because there's one cannula, That's simple. You put the cannula about 8 centimeters away from the mouth opening and you deploy the instruments. What you end up spending time with on the single port is your orientation, whether your camera is above or whether your camera is below, because they can be either or. And then your two instruments coming in from the side. And so you spend time by placing those and you say, maybe in this case, my camera fits better below and my instruments can come above, or vice versa. And so you play in with it. So that's part of your docking time. So there's a little bit more time on the single port than the XI. The XI is just basically straight, the triangulation, everything, but you don't have that with the single port. But it's not a huge difference between the docking. In terms of operative times, I think anyone's operative time is going to be longer with a single port at first, because again, it's a learning curve. The joints are different on the single port versus than what we're used to. Now there are two joints and you have to learn how to manage two joints. The camera also doesn't move as easily, I'll say, as a rigid camera, because the camera is also flexible with two joints. And so there are two ways to move your camera. There's the traditional way that we're used to, where we clutch and we move the whole camera around. But there's another way where you clutch and you click and you put it in camera mode, and now just the camera's moving around like this. And so there are two ways to move the camera, and that, excuse me, that is not simple to learn. It takes some time to learn how to manage the camera. So I think the operative time with a single port, although in our FDA trial, there wasn't much difference between my cases that I submitted, but there is a learning curve that you're going to see with that single port.
Great. Thank you, Dr. Maxson. We'll now go to the next talk. And if there's any other questions.
Thank you, everybody. Again, I'm going to mute myself and turn off my video, but everyone have a nice evening. And I look forward to seeing everyone in person one day.
Thank you very much. So the next talk would be by Dr. Rajesh with regard to anesthetic considerations for TORS. Dr. Rajesh, can we have you online, please?
Yeah. Good evening.
Thank you.
Good evening, Dr. Vidyadan. Yeah.
Good evening, sir.
Yeah, I'll just share my screen. Just a minute.
Yep. We can see you.
Yeah. Sorry, that's not the one. Sorry, I'm very sorry. It's gone to my son's view.
I think we all face the problem now when we have children.
Yeah. Just.
Sir, have you opened your presentation already?
No, not yet open. I'll just, 2 minutes. Yeah. Is it fine?
Now we can still see the digital classes.
Digital classes? 1 minute. No, 1 minute.
What you could do is stop the sharing.
Yeah.
Close this, open your presentation and reshare again.
Yeah. Where it is. Not able to. Not able to share. Okay, 1 minute, just.
In the meantime, I just wanted to say, I think Dr. Anand and Dr. Kiran has put up Dr. Scott Magnuson's contact email. So like he was talking about, his 1 hour talk on instrumentation and setup. So you can maybe email him and he will get back to you.
Rajesh sir, do you want some time so that we can?
Maybe, do you think we should go to the next talk? The Dabas sir can do his talk and then Rajesh sir can come back. Is that okay?
Dr. Rajesh sir is having a problem with his net connection.
Oh, okay.
He has just exited the.
Oh,
So,
okay. So
yeah.
Yeah.
If Dabas sir is.
Yeah, Akshay.
Sir.
I'm ready if I can share my screen.
Sure. Dr. Dabas, I think we'll go over to your talk in the interest of time and then have your discussion and get back to Dr. Rajesh.
Sure, boss. I'm just sharing the screen.
The topic for your talk is treatment intensification by TORS for advanced HPV negative oropharyngeal cancer. Thank you, sir.
So, can you hear me, Vidya and Akshay?
Yes, so we can hear you.
Yeah.
So, screen.
You can see the screen?
Yeah, we can see the screen.
So let's talk about treatment intensification in HPV negative oropharyngeal cancers. We'll just speak about HPV negative, and there is an advanced HPV negative basically. So why we say advanced? Just because of nodal disease or maybe T3 and T4. So this TORS was approved for transoral robotic surgery mainly for T1 and T2 oropharyngeal cancers. And they were not saying about nodal status, N1 or N2. So if you see the staging of oropharyngeal cancers, now it is based on HPV negative and HPV positive. So if you see T3 lesions, either they are larger than 4 centimeter or any smaller tumor which is going to the lingual surface of epiglottis is T3. So the second one is T4, where it is a locally advanced tumor just because it is going into the extensive muscle of the base tongue, involving the medial pterygoid, hard palate, mandible. So the tumor of the tonsil going into the medial pterygoid muscle fibers may be an inoperable tumor, but if it is an HPV negative tumor, even with chemoradiation, it is going to reoccur or it will be there. So can we do surgery in these patients which are lateralized and having a low volume node disease? So we'll discuss one by one. First, I will speak about locally advanced tumors just because of the nodal stations. Then we'll speak about T3 and T4. So now you see the basic difference between HPV positive and HPV negative. All publications, what we see today in literature is all about HPV positive tumors. So this is a de-intensification of the treatment where we want to lower down the treatment just because of the functional outcome should be good. And if you see the all over, there are less than 15% of all oropharyngeal squamous cell carcinomas, and having a maximum publication of the data we can say about that. But when you talk about HPV negative, we don't have an substantial data to support our evidences. And this is the major bulk of oropharyngeal cancers. And now we know from the trials of chemoradiation, this HPV negative have very poor oncologic outcomes when you treat this patient with chemoradiation as compared to HPV positive. So should we have any treatment which can improve our oncological outcomes without disturbing the functional outcomes? So if you see the NCCN guidelines, we are confused. In 2020, you see T1, T2 tumors with or without neck nodes, surgery is there along with radiation therapy. When you talk about P60 negative, T1 to T2, T3, T4 with nodal disease, again surgery is there. So what are the indication of doing surgery in early oropharyngeal cancers or advanced oropharyngeal cancers who are HPV negative? So we have done one study, it was published in 2016 or 17, and this was for stage 3 and 4 which were having nodal disease. It is not T3 and T4. Only very few T3 patients were there in the study. So we have excluded the patients who were N0 in the final pathology. So we have taken out of 153 patients. Out of this, you can say tonsil and base tongue were going simultaneously. You can say 43% patient were base tonsillar, then 38% were base tongue, then few postpharyngeal wall and short palate tumors. So now you see the maximum bulk was T2 and T1. Few were T3 depending upon not only on size but the location also. Most of the patients were having nodal disease either N1, N2A, B or C. And pathologically you say stage 3 and stage 4. Stage 3 was around 56%, 56 patients and stage 4 were 86 patients. And you see the treatment in these patients was surgery alone for early oropharyngeal cancers where it was either T3, N0 and very small tumor burden. But most of the patients required surgery followed by radiation and or surgery followed by chemoradiation. So now we see the pathological. Now if you see the oncological outcomes, now we can in stage 3, the OS and DFS was much better when you treat this patient with surgery and then give radiation or chemoradiation. Stage 4, again the OS was again good. It was in the range of around 88% and DFS was good. But RFS recurrence-free survival was around 76%. If you see the literature, RFS in advanced stage oropharyngeal cancer is in the range of around 50% if you treat this patient with chemoradiation. So what we decided, if you treat these patients with T1, T2, N1, N2A, N2B, C with surgery and then give radiation therapy, you have a good oncological outcomes. And if you analyze the functional outcomes, we have analyzed at 1 year, the functional outcome is as good as we can say before treatment. But the functional outcomes, the patient who require radiation or chemoradiation after surgery at 6 months is not good, but at 1 year, it's absolutely normal to the pre-operative level. Now, if you talk about T3 and T4 tumors, we don't have literature about T3 and T4 tumors who are operated by robotic system. But if you see in past, this was a paper in 1998 by Dr. Bruce Hoge, and what he suggested for T4 tumors or T3 tumors, the patient who has good general condition, the combination therapy followed by post-operative radiation therapy offers you the better control than single modality, but with great morbidity. So now how we're operating this patient, either we're doing laser or we're doing open surgery. So everybody knows the morbidity of open surgery is much higher as compared to laser or endoscopic surgery or robotic surgery. But one thing was clear, the oncological outcomes was good if you treat these patients with surgery and then give radiation therapy. So the local control was much higher with surgery. So this was the paper, and you can see the majority of patients were T3 and T4, and analysis says the patient who has N0 neck or N1 neck and you treat this patient with surgery, the oncological outcomes was much better. But again with morbidity, so this paper was just, I was showing just because of the oncological outcomes. Now when you treat this patient with transoral laser microsurgery, where the morbidity we can say is less. So again we have T3, T4 tumors or T1, T2 tumors. And this paper showed if you treat T1 and T2 tonsillar cancers versus T3, T4 tonsillar cancers, there was no much difference in local failure when you treat this patient with surgery. And we can see with this uh, diagram. So what were the analysis? Surgery should be the first treatment for these patients who are locally advanced T3 or T4 tonsillar tumors. So this was the analysis. And we know whatever way we treat this patient, either with surgery or radiation, the morbidity and complication are higher as compared to T1 and T2. But the functional and oncological outcomes were comparable to other treatment options if you treat with surgery. Now, this was paper by Zengai et al. It was for T4, only for T4 oropharyngeal cancers, maybe HPV negative and HPV positive. So it was showing for either it is HPV positive or negative, if you do surgery for these patients, their OS and DFS is much better as compared to chemoradiation. So when we treat these patients with surgery, by these three papers, we can say that mainly the tonsillar cancers and some base tongue cancers, the survival is much better than chemoradiation. So it showed we found a survival advantage with primary surgery. Those treated with non-surgical therapy had 2 to 3-fold increased risk of death or disease reoccurrence. And other benefits we know, we are able to do a complete pathological analysis of the tumor, which is must in nowadays. We can downstage or upstage the patient disease, knowing the nodal disease is negative or positive. We may reduce the dose of radiation therapy post-surgery, leading to less morbidity, and sometimes we can avoid the chemotherapy along with radiation therapy, and we can decrease the morbidity significantly. So I'm just showing what we do. You can see this patient having tumor on the left side, and you can see the tumor. It's a big tumor involving the tonsillar fossa going to the base tongue. So what I say is a lateralized tumor involving the tonsil and going to the base tongue and just encroaching the midline and bulging and towards the opposite side. And we don't find any neck node on PET CT. So now should we go for chemoradiation or should we do surgery in this patient? So we opted for surgery first by seeing the analysis of Western literature about T4 tumors. It was T4 tumor basically. The only point is we have to go for reconstruction in this patient when you take out major part of the base tongue and you are taking the tonsil also, to avoid any palatopharyngeal insufficiency. So again, your planes are same. You have to make a plane between the superior constrictor and the medial pterygoid for doing a radical tonsillectomy. Then you have to go to the base tongue. You have to do a compartmental extension of the base tongue going midline up to the hyoid bone. You can see the neurovascular bundle. You can see the nerve and the lingual artery. This is the palatoglossus muscle. This makes a deep margin of the tonsillar fossa. The vessels coming in between the palatoglossus, styloglossus, and the stylopharyngeus. Sorry, this stylopharyngeal we are cutting. This is a nerve. We say the glossopharyngeal nerve. We are cutting right now. Yeah, this white structure. So we are doing a compartment excision of the base tongue, plus we are doing a radical tonsillectomy. So we can see the hyoid bone there. So we are going deep down till the hyoid. We can see the epiglottis. So this defect need to be reconstructed always. We can see the gland. So what we do when you do a neck dissection, you take out the gland and make a tunnel between the neck and the oropharynx, and then deliver the flap through the nest defect and put inside, and then you suture. This is the very important part of doing a free flap reconstruction. You are suturing the distant mode defect near to the vallicula with the robotic instruments. Other part you can do by open method by using a headlight or using longer instruments. So one part when you're doing a free flap reconstruction or insetting with the robot, once you have inset the flap anteriorly near to the base tongue, you should always try to pull the tongue out and see your flap is not short enough. The flap should be larger enough so that you can cover that defect. It should not be a smaller one because otherwise there is a lot of wound dehiscence. So this is the final picture after surgery. This is the lateralized defect. So one point, we should never put the bulk of the flap on the palate or sorry, on the epiglottis. It may lead to aspiration later on, or it may lead to stridor. So always the tumor should be lateralized to go for a reconstruction with free flap. So we have literature about doing a robotic assisted free flaps in head neck reconstructions. And we can say the robot is required basically in a remote access, like near to the base tongue, just to cover the hyoid bone. So now a lot of things are in mind. Should we do surgery for this advanced tumor and put a free flap? The functional outcome may not be good. Maybe the oncological outcome is good. What about the functional outcomes? So now we are evaluating the functional outcomes for these patients, and we have done around 40 patients till today. But we have done functional analysis in around 16 patients. And what we do, we start swallow therapy post 1 week of surgery in all free flap surgeries with a RAL tube in situ. And we then do a functional oral intake score. And we take out the RAL tube once your functional score is at level 5. So this is the functional scoring we always use, level 1 to level 7. At level 5, you take out the RAL tube. And you always need a good swallowing therapist in your team if you want to do good oropharyngeal surgeries by robot or laser. And what we are seeing, most of the patients were able to start their oral diet within surgery before starting your chemo radiation. The problem is that when you start taking oral diet and then within a week or 2 weeks you start your radiation or chemo, the patient always says, I was able to take normal diet before my radiation was started. So if we can avoid, like in T4 tumors, N0 neck or N1, we can avoid chemo. Most of the patients have good functional scores, maybe after 3 months of chemo radiation or radiation. So the mean time to reach to level 5 was around 26 days. And aspiration, we can say, if you select your patient very wisely, then aspirations events are very less. You can say none in out of these 16 patients. So what I conclude from this is we can use TOS in advanced oropharyngeal cancers. Either it is because of nodal disease or T3, T4, but you have to select your patients very, very wisely. Don't try to take out the base tongue, which is in the midline, and then you take out the midline with the robotic. You can take out the tumor, but how to reconstruct that? That's the most difficult part to do that. So try to select the lateralized tumor, maybe advanced one, so that you can do a reconstruction of the free flap. So T3, T4 tumors with low volume neck are best suited for TOS if you want to do surgery for these patients who are HPV negative. Otherwise, locally advanced oropharyngeal cancers where you are not suited for good reconstruction or you are not well experienced with robotic surgery, you should not start it with. You should do good surgery by T1, T2 tumors, like Professor Scott told you about T1, T2, tonsil, then base tongue, then supraglottic, then piriform sinus. Say, come again T3 and T4 base tongue and do a reconstruction with that. And it will take time to learn this, but I'm telling you, if you see the functional outcome, it is much better as compared to chemo radiation. But always, your plastic surgeon should be good enough to do these surgeries. Thank you so much.
Thank you, Dr. Dabasa. It was a very stimulating and inspiring talk. You're kind of paving the way for surgically dealing HPV negative oropharyngeal tumors here in India. I'm also very happy that you've stressed the importance of functional rehabilitation post-TOS. Somehow I feel, maybe our international faculty can give their points with the Orator trial. If you do intense rehabilitation, people can get back whatever lost function with this kind of option, surgery with adjuvant radiation therapy. The question, I just want to check if there's any questions.
Vidya,
Yes.
Can I answer on this?
Yes, sir.
So the biggest point in Orator trial was that all patients, they were tracheostomized before surgery.
Okay.
Even for smaller tumors. And doing a tracheostomy in a patient leads to very bad functional outcomes, even it is open surgery or robotic surgery, whatever.
Okay.
And why the tracheostomy was done in all patients, just because one patient expired because of bleeding, I don't know, but they had a protocol to do a tracheostomy in all patients. Then you should not do any functional outcomes when you're doing tracheostomy in all oropharyngeal cancers.
True.
And the scoring was done mostly at 1 year. And if you see the chronic side effect of radiation therapy is usually after 2 years. So what we are more focused about is chronic side effect of radiation therapy rather than acute side effect.
Delayed effects.
And the number of patients is very less, so we should not compare like this.
Sure. Thanks. But for you, in my question is, what would be your next step for here in India? What do you think to take this forward? Are you thinking of some kind of a trial or some kind of I mean, what would be the next step?
Is Dr. Kostav there? Can you unmute Dr. Kostav?
And also, if anybody in the international faculty would want to join in, it'll be great if they can say what their opinions too.
Lydia, it's John de Almeida here. Can you hear me?
Hi, John. Yeah, hey, welcome.
Thank you. So I was actually part of the Orator trial. Being from Toronto, we supported the trial, which is a Canadian-led trial. Just want to make a couple of clarifications about some of the endpoints that were interpreted and how they're interpreted. First of all, not every patient received tracheostomies. In fact, I never trach our patients when we do robotic surgery. This was sort of a decree from Tony Nichols, who was the PI on the study. It was a recommendation, but not an absolute recommendation, or it wasn't enforced. So what they did, what Tony did is a subgroup analysis comparing the MDADI scores in patients who were tracheotomized versus those who weren't. Obviously, we all know this is a very small population of patients, 34 patients per arm. And there was no significant difference in the MDADI scores on those who are trached and those that weren't. I know this comment comes up a lot at all the meetings, all the robotics meetings, that tracheostomy leads to adverse sort of swallowing outcomes. And that might be true in the short term, but remember, these outcomes are determined in the long term. Second of all, I think we got to be careful with interpreting the outcomes, comparing it to radiation. And I know this was how the study was powered, but it is a small study. I think it's hypothesis generating at best. And we should use it as that because it wasn't a definitive trial. And the point that was brought up about long-term sequelae of radiation is absolutely true. When we're interpreting outcomes at 1 year, we're really ignoring some of those late toxicities that we see with radiation.
Thank you, Dr. Almeida. It's good to clarify that point. And it's good to have these meetings because when we discuss personally, we learn more points and we dissect these papers a bit more. Thanks a lot. Dr. Patel, your comments, please.
So, I have been always telling Dabas that the numbers he is doing and the publications for HP negative, what he has done is phenomenal. And we at India, we must start a multi-institutional kind of a trial for this with a protocol where, multiple centers can come up and we do a prospective trial. I think that will probably, give the world an idea about what HPV negative patients and TORS can put up as a, future guideline.
Yes, sir, because of our volumes too. So thank you, sir. So if there are no more questions and no more comments, should we go on to the next talk?
Vidya?
Yeah.
I want to say one thing.
Vidya,
Yes, sir.
Vidya, can I say one more thing?
Yes, sir, of course.
So, I'm talking about 80s and 90s. We used to do mandibulotomy and base tongue and tonsil resections followed by radiation when chemoradiation was not in vogue.
True.
And I must say that the oncological results were really good. It was not that oncological results were inferior. The only thing is what happened when chemoradiation came, the morbidity was supposed to be decreased compared to the mandibulotomy surgery. So once the TORS has come, it can be a game changer because morbidity, if we can prove that morbidity is equal and the oncological results are better, then I think that is what the world is looking at.
True, sir. And especially even the point. Yes, sir.
This one point. See, my say is always the patient is going to a dentist or an ENT surgeon first. We have to train them and you have to tell them this is a treatment option for this cancer. Still now, I've said 95% of the ENT surgeons or a dentist, they don't know about what is robotic surgery for oropharynx. And if you want to involve a new technology, we have to tell them about this technology is good because see, we are seeing 80% advanced cancers. Why?
Awareness.
Physician negligence, we can say that. So if you are trained enough to find early cancers, I can say that if we have 100 head and neck surgeons, we can come with the data which can, within a month or 2 months, we can provide such large data. We can prove that this is the best treatment option for HB negative cancers.
Sure, sure. Thank you so much. Thanks, sir. So I would now go to the next talk. Is Dr. Rajesh ready?
Yeah, I'll just try to share.
Welcome back, Dr. Rajesh.
Yeah. Or else Dr. Akshay, I have just forwarded my slides to Dr. Akshay.
Should I share or you
Yeah, you can share, Akshay. Yeah. Yeah. Fine. I'll start now. It's visible, I hope. Yeah. Okay. Good evening to everyone, and I'm very thankful to the Academy of Head and Neck Oncology of Karnataka and the HCG academics and Dr. Akshay and the team, Dr. Vishal, everyone, for inviting me to give this talk on anesthetic considerations for TOS. So my first few slides coincides with what Dr. Scott already has discussed. So TOS, usually it's a minimal invasive approach to deep-seated tumors of the cavity, which enhances the visualization of the anatomy that is not within the site using conventional instruments like a rigid bronchoscopy, endoscopy. The surgical area is seen in high resolution and with improved depth of perception, facilitating resection with precise tremor-free movements using wristed robotic instruments through narrow openings. Next slide. So it was first introduced by Winston. It was discussed by Dr. Scott also in 2005 on a canine model. And next slide. And again, in 2005 or 6, the same, this one was a varicose cyst was excised using a Da Vinci robotic assisted system. Next slide. This was the picture photos of the first patient who undergone this robotic TOS procedure. Next slide. And in 2006 and 7, the Pennsylvania University demonstrated the feasibility and safety of transoral resections with Da Vinci. And by December 2009, the FDA approved the same for most of the tumors, head and neck tumors, oral surgery and head and neck tumors. Next slide. So the benefit of TOS is already, as discussed, it allows the true three-dimensional endoscopic vision of the surgical field with accurate depth perception. We all know that. And there is also a very quicker return to the normal speech and swallowing. Significant less pain is seen. Here there is a query because the first 24 hours, I have seen where the patients come in a lot of pain, but after 24 hours, definitely there is less pain compared to the open surgery. There is decreased blood loss also, and there is decreased length of stay. Next slide. So these are the indications which have already been discussed. Next slide. So here, next slide, yes. So next, we start about how we go about for the perioperative care of a patient posted for the TOS. So we take an opportunity here, the anesthesiologist, to meet the patient because these patients are usually posted for pan endoscopy to assess the feasibility of the TOS and the surgical exposure. So this is the time we as the anesthesiologist will have to plan a step ahead of the proper major invasive procedure. So that involves a very thorough pre-anesthetic evaluation and the perioperative investigations. Here, preoperative investigations are routine as we are considered to any other oral surgeries. Preoperative assessment, the patient should undergo standard preoperative assessment with particular considerations to implications of their diagnosis on general health and their premorbid conditions, especially smoking status and the chronic respiratory disease, CVD, and hypertension has to be assessed. And the review of the potential sequelae of OSA for some patients who might extubate the patient on table has to be assessed. Next slide. So continuing the history of antithrombotic or the antiplatelet medication is very important because most patients are on coming here are all elderly patients who are on aspirin, ecosprin or antiplatelet medications. that we have to see to that it has to be stopped at least 5 days or 3 days prior for this to the surgery. And the one more important thing is the nutritional status of the patient, whether he has real nutritional deficiency or the operative or the preoperative dysphagia, that has to be assessed. Then the formal airway assessment, which has to be very meticulous, because most of the pathology involves the intraoral lesions, which have significant bearing on the ability to perform the bag mask ventilation and also most of the times direct laryngoscopy. So the other part is the dentition. If the dentition is poor, the trauma due to the involving the TORS instruments has to be assessed very much. Next slide. So this, Scott has already told, this is the normal thing. Next slide. So this, we have reversed here in our, this is our institutional photo which I have put now image. Here we have reversed whatever Dr. Scott has told, or the normal thing has been done. We have reversed here. The surgeon is in the foot end and the anesthetist is in the head end. You always believe, we always believe that anesthesiologists should always be in the head end. So here we have kept our workstation and our anesthetist is sitting in the head end, and you can see there are a lot of space available there actually. So it depends on the individual, the institution, protocol, or the space or the dimension of the OT that involved in that institution. Next slide. Next slide. So the airway management of the TORS. So once we assess the extent of the cancerous growth or the tumor, and the possibility of the airway obstruction, following the guidelines of the ASA, that is American Society of Anesthesiologists guidelines of difficult airway, the airway management has to be followed very meticulously. So the availability of the fiber optic bronchoscope, video laryngoscope, cricothyroidotomy sets, and the tracheostomy sets has to be available and to be confirmed with before the patient is wheeled in. So anesthetic induction should always encompass a technique for the patient. Next slide. So here we usually prefer the nasal intubation with a RAE endotracheal tube, which allows optimal access for the robot with minimal obstruction to the surgical field. If a difficult airway is suspected, awake fiber optic intubation and high flow nasal cannula can provide the oxygenation. If the lesion involves the base of the tongue or the larynx, we perform a percutaneous tracheostomy beforehand and we induce the patient. Once intubated, it is always mandatory to check the endotracheal tube cuff pressure to ensure minimal leak is present, thereby protecting the airway from the blood or the debris that may track down the surgical site. So spontaneous respiration should preferably be maintained till the insertion of the definitive airway, and muscle relaxant must be given only after confirming the correct tube placement. So maintenance of anesthesia is either by total intravenous anesthesia or by the volatile gases. We combine both, and I'll tell you why later. And some patients where the significant cardiovascular disease or they don't tolerate the extremes of heart rate and blood pressure, we always put the invasive arterial monitoring. And wherever necessary, a central venous catheter is necessary, we put the femoral venous or the subclavian vein. So deepening the plane of anesthesia during the oral introduction and the setting of robotic instrument as done by raising the infusion rate of the intravenous propofol or increasing the inhalation anesthetic agent. So why I told is usually wherever we see the most of the elderly patients, the hypertension or the COPD patients, they tend to aggravate, the hypertension tend to aggravate very like a malignant hypertension. So before the surgeon introduce the FK retractor, it is always better we use the propofol infusion or we increase the inhalational anesthetic agent. Next slide. So how we do that? Either by the inhalational or by the induction agents like propofol, and also with esmolol, nitroglycerin, labetalol, and also intermittent opioid boluses also. Next slide. So the position of the patient is also very important, and to protect all the necessary damage which happens due to the positioning of the patient. Here you can see we apply a goggle to the patient so that when the surgeon insert the instrument will not injure any part of the patient's eyes or the neck, face. Next slide. So the patient is placed in such a position that it provides adequate neck extension for surgical access. Care should be taken for those patients with restricted neck extension of arthritis or cervical radiculopathy. And molded dental guards are used to protect the patient from potential dental injury from the robotic instruments. So the other part, the minor things, but which helps in, because we always keep our anesthetic workstation on the head end, till we require the longer extension lines for the intravenous catheters because the hands will be down. And we have a extra long anesthetic circuit, which is we always use for robotic surgeries. And the inspired oxygen concentration is, we keep it very low at around 33%, such that if any cautery or any burn is there, it is controlled with the less decreased inspired oxygen concentration. Next slide. So coming to the pain management, the post-operative anesthesia, as I told you, most of our patients I have seen the first 24 hours, they have a lot of pain with, because not of the excision, that's because of the pulling of the oral cavity. But it settles down within 24 hours. So we usually give a combination of multimodal anesthesia, analgesia like paracetamol, NSAID, and also sometimes with fentanyl infusion. If necessary, we may also give some mental block or the superficial cervical block, plexus block. We have done it on 2 or 3 patients, but usually the analgesics are sufficient. So one more, the major complications which may happen post-operatively is there is a study where there are 224 patients, around 9.8% of post-surgical hemorrhage has been seen. And this usually is seen within the first 2 weeks and around 7 to 9 days. So that has to be kept in mind. And what is the extubation plan? This is the most important step for an anesthesiologist and for the surgeon. So this has to be done by the case-by-case decision making, considering the feasibility of extubation with the surgeon. So there are three mode of planning of extubation. One is to extubate on the table. Second is to intubate the patient, keep the patient intubated and sedated in the ICU for a day and extubate the next morning, or if appropriate, tracheostomy. So if extubation is appropriate on the table, then all the sedatives and the neuromuscular blockage should be fully reversed. The patient is made to sit up to 34 to 45 degrees and undertaken in the presence of the surgical team. So the University of Pennsylvania recommends that when the patient is intubated, are sedated and ventilated, these indications are there, like dissection is adjacent to the vallecula or epiglottis as there is suspected associated airway edema, in prolonged cases in which lingual edema is suspected, and in all TORS supraglottal partial laryngectomies. Then tracheostomy is advocated in any resection involving resection of the tongue base and a portion of the epiglottis. In any patient where postoperative emergency reintubation is expected to be difficult, or a patient with medical condition like morbid obesity. Next slide. Oral intake. It's one of the most important part of any oral surgery. So as already told, the preoperative history taken, but like the symptoms of dysphagia, dysgeusia, nasopharyngeal reflux, everything. So a nasogastric tube has to be facilitated postoperatively to feed at the end of the surgery. Or in most of the literature, wherever I have just gone through, there is around 18 to 39% of patients who have undergone temporary gastrostomy, and also around 7% patients requiring percutaneous endoscopy gastrostomy for at least 3 months. So coming to the key challenges, the final few slides. First is the airway assessment. the prediction, everything. You have to get ready before the patient taken to the OT. Anesthetic induction has to be planned. The anesthesiologist and the anesthetic machine is located at the patient feet, but in our this one, I already told, we keep it in our head. So any intravenous line extensions or tubing extensions has to be very long. And potential robot arms to the injury to the face and eyes protection has to be done well. And most importantly, practice drills, because these patients suddenly they may go for bradycardia if it is not, the patient is not too deep, and when we introduce the instrument. So always a practice drill to help to simulate emergency undocking is very important. And good muscle relaxation and to cut down the intraoperative sympathetic stimulation. So there is a risk of airway 5. That's why the oxygen concentration is kept at around 0.3. Airway trolley is always kept inside the OT, and post-operatively plan the extubation depending on the classification of Pennsylvania I already discussed, and this swallow function because of acute dysphagia. So, and as this patient are very physiologically very cumbersome, so this patient has to have a closer physiological monitoring in a high dependency care or intensive care unit, and it is very important to have a local guidelines to support the standards of perioperative care. With all this, definitely TOS allows us the exceptional surgical treatment of head and neck disease while minimizing morbidity and improving functional outcome as compared with open surgical approaches. Thank you very much. This is our first case 4 years back. We were very happy that Dr. Abbas was the mentor for that. And you can see our surgeons, all the 3-4 surgeons in the side, they're all very enthusiastically seeing what he's doing. Thank you very much.
Thank you, Rajesh, sir, for a very thorough talk. I have 2 questions. One is when the surgeon is putting in this is for the benefit of all the surgeons.
Yes.
When your surgeon is putting on the retractors, what are the vital sign changes, or what are the hemodynamic changes that you notice, or how do you know the patient is pain, and when do you tell the surgeon?
Yes, so that's what I told. See, before introduction of the instruments, we have to take the patient very deep. So in such a way that the patient, the hypertensive reflex or the sympathetic reflex doesn't exaggerate. So the induction agent, all the inhalational agents, we increase the inhalational agents like sevoflurane, desflurane, or we increase we give the bolus of propofol, the induction agents, or we have other drugs like labetalol and nitroglycerin, like that. So using that, we always try to come down with it, because most of the patients I already told are elderly patients with hypertension. The basic blood pressure will be around, systolic will be around 180, 160. So we have to see to that autoregulation is also not lost in the same this one. So the hypertension also will cause a lot of problems post-operatively. So you have to maintain a standard autoregulation for these patients.
So during the surgery, you would know, and you tell the surgeon, look, I need to put the patient a bit more deeper, and so that you can.
No. If I tell that, then I'm not a good anesthetist.
Okay. The second question is regarding what is your protocol in your hospital regarding managing a bleed or a post-operative bleed in the ward? So what do you do? Do you shift them immediately back to the theater, or?
Yeah, see, according to our experience, we have done around 30 TOS along with neck dissection, around 30-35 since last 4 years, with the 6 reconstruction also. So with all these TOS, we have not experienced any postoperative hemorrhage, because I saw a lot of literature telling me 9%, 7%, 19%, but we never saw even one case with any hemorrhage. But we have seen that in open surgery cases. But what we do is, that's why I don't extubate any patient, even though it is a simple tumor excision with simple free flap. I don't extubate for 24 hours. Electively, I keep the patient on the tube, and next day I extubate, or if it is a very bulky flap, then I extubate them after 48 hours. So I have not seen the emergency hemorrhage till now, actually.
Sure, sir. Thank you, sir. I think Dr. Duveri wants to make a comment. If Akshay, could you unmute Dr. Duveri, please?
Yeah, Bhargav, please unmute Duveri.
Bhargav.
Actually, Bhargav has got the.
Oh, I think now it maybe it is unmuted.
Yeah.
Great. Okay.
Very good. Well, good evening to you guys. Morning for the people in the US. Just had a couple of comments. First of all, very wonderful lecture on the anesthetic complications and anesthetic indications. Regarding the bleeding issue, I think that maybe the reason that luckily you're having such low rates of bleeding is that you've gained some knowledge from the hard knocks that we have taken, on the front end, so to speak. I hopefully that people are using vessel ligation, which has been shown to reduce bleeding. In fact, it reduces the front pressure associated with this. And I'll talk a little bit about that. That may be the reason for having a reduction of bleeding complications. So that's a very good thing. And then if the bleeding complication does happen, hopefully it is not nearly as severe as you would expect from other situations. So that's another point. Second is regarding the choice of intubation tube, the endotracheal tube. We have had a few cases where if the endotracheal tube is done transnasally, if it is not long enough, in other words, the length of the tube is also important as you manipulate the head, especially for deeper tumors, as Dr. Dabas has shown in his very elegant description of the operations. The bigger the tumors you tackle, the more manipulation of the head will happen. There'll be shifting of the head back and forth. And as such, you can have accidental extubation, or maybe not complete extubation, but backing off of the tube so that there is a greater chance of the cuff being at the level or above the level of the glottis, which can lead to potentially leakage. And if you are not as careful as Sir was in maintaining the oxygen levels at 33%, if they become higher due to some hypoventilation, et cetera, then there's a potential for airway fire. So just something for the surgeon as they're sitting at the head to remember to periodically check the tube, and just to make sure that you don't have an accidental extubation or a cuff leak.
Thank you, Dr. Uri. I think we're building up on the shoulders of the people who already tried and tested and published. So that's how maybe the complication rates are, like you said, it's a bit low. There are two more questions for Dr. I think this is for Dr. Dabas, or anybody can take this question. Is there a robotic system which integrates and allows the use of narrowband imaging to help ensuring getting better clear margins, surgical margins? This is by Dr. Spiteri.
Now, Vidya.
Yes, sir.
Till now, we don't have any narrowband imaging which is coupled with robotic system. But maybe in future, like in where you do colorectal surgeries, you have an Firefly technology. And this is an XI system basically, and you can use to see your resection margins very well. It is vascular or not for making an anastomosis. We are not using any Firefly technology in head and neck, but if you want to see the vascularity, yes, you can use that. We don't have a narrowband imaging, but Firefly technology can help in that. But margins assessment is not with Firefly technology. We can just see the vascularity. Maybe in future we can have that.
I think Dr. Spiteri was also mentioning narrowband imaging. This is with, I think he's extrapolating it from the laser.
But it's not with robotic system.
And the second question is by Dr. Gopal Kumar. He says, is there any role of neoadjuvant chemotherapy in oropharyngeal cancer for T3, T4 lesions followed by surgery?
So Gopal is coming from a center where I think he has seen Professor Kim, who is doing neoadjuvant chemotherapy in supraglottic tumors. And then what he get a CR and then resect the same area which was having a cancerous growth. But in oropharynx, I have never seen him doing any neoadjuvant chemotherapy and then doing surgery. Yes, I was doing Anesthetic and doing surgery, but I told Gopal privately that all patients recovered within 6 months. I have never attempted after this. So Anesthetic in oropharynx, I don't recommend. But yes, if you do Anesthetic and there is good response, you go for RT rather than surgery.
Thank you, sir. So we'll go to the next.
Can I make a comment? There is actually some ongoing studies about that very question, neoadjuvant chemotherapy. In fact, the George Washington University in the US and now McGill University have two active trials on this. not necessarily for HPV negative, but using a doublet agent, I believe it is. I think it's I can't remember the exact agent, but I think it's a taxane and platinum given with 3 cycles, and they're going in to resect post induction chemotherapy, and they're seeing some very good preliminary data on this. It's called the NECTORS trial, but so it's not specific to HPV negative, but it's being used for robotic surgery.
So it's an NET TORS trial. NET as an NET?
Sorry?
NET as an NET.
NECTORS, and NECTORS is an English.
Nectar, okay, yeah. Thank you, Dr. Almeida. So we'll go to the next talk. This is the next talk is by Dr. Ofo, Mr. Ofo. It's a transoral tongue-based mucosectomy for identification of the unknown primary site. Can we have Mr. Ofo online, please?
Yeah, thank you very much. I just need to make sure I get the right
slide.
The right slides. Okay. Great. Thank you very much, Dr. Vijay and Dr. Akshay, for this invitation. You brought together a fantastic meeting. You should be very proud, and I feel very honored to be part of the faculty. I think we've got a lot to cover in a very short space of time, so I will try to be quick. We'll just go through a brief introduction, cover the role of TORS in the unknown primary setting, touch on a few technical tips, and finish with a discussion in summary. So because this is quite an interesting topic, and we won't really do it justice in 15 minutes, there's a great review article. It just so happens that I'm one of the co-authors with Uma, so we have to say it's a good paper. If you want more information, you can get that from this paper. We've already covered what robotic surgery is, so we won't go spend more time on that. But we all know that the intuitive motion and the endo-wristed instrumentation makes it an excellent tool for accessing the upper aerodigestive tract. Now, with regards to squamous cell carcinomas of unknown primary, we know it's a diagnostic and treatment challenge because there's additional morbidity in treating patients to cover suspected sites. For example, there are some centers that use total mucosal irradiation, for example. And we know that for the majority of patients who are HPV positive, these tumors, they're sometimes, only a few millimeters are hiding in the tongue base or tonsil. So for that reason, if we can find the tumor, you can direct your treatment specifically to the actual site where the disease has arisen from, avoiding additional morbidity. And there are some studies showing that primary site identification is associated with better oncological outcomes. So the standard protocol for most centers, most head and neck centers, would be a comprehensive clinical examination. I know that COVID has made things a bit more difficult because nasoendoscopies, for example, is considered an aerosol generating procedure. However, I think we've sort of come around to continuing with that examination because it is quite critical. CT and MRI scans would be a starting imaging, and then you proceed to a PET CT scan if you don't see anything obvious. Some centers would then proceed to panendoscopy and blind biopsies if all the imaging was negative, and most people would do a tonsillectomy, and there's a debate over ipsilateral versus bilateral, but most people would probably go for a bilateral tonsillectomy. And we know that CT or MRI will pick up another 9 to 23% of tumors, so not as sensitive as we would like. If you then add in a PET CT, it's not as great in terms of its additional primary tumor detection rate is in the region of about 37 to 44%, depending on which bits of the literature you read. And it's not very good for small sub-centimeter tumors. So we need additional tools. The other problem with PET CT, which is commonly available in most centers, is that it has a high false positive rate, especially from normal physiological uptake in the base of tongue and other lymphoid tissue within the head and neck region. And you can get a lot of false negatives as well, where pathological uptake is still considered physiological. We have a term for nuclear medicine in the context of PET-CTs is sometimes referred to as unclear medicine. If you use a palanoscopy, endoscopic guided biopsies, you might pick up another 60% or so of tumors that would otherwise have been classed as unknown. And ipsilateral versus bilateral tonsillectomy, a tonsillectomy alone, you'd probably pick up 18 to 44% of occult tumors, and you have positivity rates in the contralateral tonsil of between 10 to 23%, which is why some centers would perform a bilateral tonsillectomy. So what do you do if after that comprehensive diagnostic workup, you haven't found the primary site? And why is it important? Well, in the case of HPV positive oropharyngeal cancer or HPV positive neck disease, we know that 80 to 90% of these are situated in the oropharynx, either the tonsil or the base of tongue. So for that reason, if we can improve the ability to sample, so this is taken from that paper I showed you, if we can sample this base of tongue or lingual tonsil in addition to the palatine tonsils, if we can remove all of that and send it for histological analysis, we should hopefully improve our pickup rate. So for that reason, when we looked into this, and this is just a UK paper, 3 centres, St George's, Oxford and Newcastle with Vimpeleri there at the time, we looked at our experience and we found that we were able to pick up an additional 53% of base of tongue tumours, and we had in 12% of patients contralateral base of tongue disease. So this showed the added value of a robotic tongue-based mucosectomy. And since then, there've been, or even just prior to that UK paper, there was this paper from John Almeida's group that did a very good systematic review, looking at the role of not just transoral robotic surgery, but transoral laser microsurgery. And they found that you can pick up disease in the lingual tonsils in another 72% of patients that would otherwise have had no clinical evidence of disease. And that was obviously a valid value. The bleeding rate was in the region of about 5%, which was the most common complication. There was a more up-to-date paper by Mahena's group, again, another systematic review that had slightly bigger numbers, and they found a 53% detection rate with TORS. So what are the benefits of TORS versus TOALM? So as you can see, you could use the laser for this. You don't have to use the robot. You can use an endoscope and a monopolar, but with the robot, you get much better visualization. The instrumentation is much better. So if you have access to a robot, it's a fantastic tool to do a tongue-based mucosectomy. In addition to that, for those of you who are starting your robotics practice, this is a nice, safe way for you to get used to doing robotic head and neck surgery. And we know that with the laser alone, you can pick up another 68% of tumors. With the robot, you can pick up to 100% of tumors that would otherwise have gone undetected. So again, it's a no-brainer. I think you will struggle to get your hospital to buy you a robot just to do tongue-based mucosectomies, but if you have one, then you have good evidence there for you to use this tool. So this is a picture from a figure from the paper again, just showing the various steps. This top one here, we've made an incision in the midline, and then you cut across. I'll probably better describe this to you on the video, so I'll stop sharing that and try and share my screen again and get a video up. So let's play that from about there. So I'll try and speed this up. Actually, this is the wrong one. I'll stop sharing that. Share screen. Okay. So let's start with this one. So I'll try and talk through a few technical things here, just so that it makes it a little bit more interesting. So just so you know, this is actually unedited. So this whole procedure, this timeline is 27 minutes. And when you first set up, this is just using a Ball Davis gag, and you have your tongue blade just behind the circumvallate papillae, so you can visualize the tongue base. And I will speed this up just for the sake of time. So that just demonstrates, as I said, you make your initial incision in the midline. It's useful in terms of orientation, especially if you're going to do just one side alone. And we can discuss ipsilateral versus bilateral tongue-based mucosectomies. I've deliberately left this unedited, just to again show you how you get a lot of smoke when you use the monopolar. So you do have your assistant needs to pay attention, and they do need to have appropriate suction. So this is actually a trainee video as well. And what you can see here is what Scott was describing earlier, how you can see how there's a lot of movement in the arm component of the instrument, which we've been able to get away with with this because there's enough room, but you might struggle for room in order to, and then you have a lot of instrument clashes. So you want more of your movement from the tip. So this is an 8mm monopolar, and this is a fenestrated bipolar. I find that the fenestrated bipolar gives you a bit more traction. Now, and I'm just going to take that back just a little bit, because again, another sort of trainee tip here is you might see how, in order to get traction, the temptation is to grab the mucosa too early. And as you can see, you haven't got that haptic feedback. So you're not quite there. And if you keep persisting, what happens is you end up traumatizing the mucosa, and you make things bleed. So you just you have to be patient and allow yourself enough time to get into the right plane, so that your bipolar or your Maryland has enough of a grip before you can get that traction. And this is a common sort of, for those who are starting off in their robotics pro, you might find that this is a bit more of a challenge. But once you've got into the right plane, you can now a good grip and proceed with the resection. We'll speed up a little bit again, just for the sake of time. So important tips as well. This patient had a previous tonsillectomy, which you might be able to see here, a bit of slough there. So it is important that you get all the way to that glossotonsillar sulcus as well, in that region over there, because you could miss some small tumors in that area. So you need to get right up to that glossotonsillar sulcus. If you're doing the tonsillectomy as well at the same time, you can take the whole thing with you. And then once you're in the right plane, it's very easy. I'll show you another video where using the tip is demonstrated a bit better, as opposed to more of the arm. And another tip as well is making sure that you try to avoid creating too many planes, which again is a common mistake when you first start. You can see how there are several lines of cuts here, which you can get away with, but what you want to try and do is to be consistent, so you avoid all these different cuts within your specimen, essentially. So the important thing is to make sure you get all the way down towards the vallecula, and you can see here again how there's just a little bit of tissue that was left behind here, which you can tidy up, but it doesn't look as nice, if you can get everything up in one big block. So I will stop that there, and then quickly demonstrate. So as I said, you really want to get all the way down towards the vallecula to make sure that, again, you haven't missed tumors that are a bit lower down. So I'll stop sharing that particular one. This is just to show you that's that done. And just give you another one for comparison. Let's give you that one instead. Just stop that. Okay. And the one underneath it. So this is demonstrating it with a slightly different instrument here. This is the 5mm spatula. You get a bit more of a wristed action with that 5mm monopolar. And you can see how here the difference is. You see how the tip is moving a lot more. So that way you're able to work in a much better confined space without having the whole arm moving. Let's see if we can just again speed that up just to demonstrate the difference there with the tip moving. Let's give you that. So see how there's less movement from the arm and it's more the tip. Let's give you that tip action. So you can see that there. So it just avoids the arm catching on the teeth. And here, once you get into the right plane, it makes life a bit easier. So just a few technical things there. I will stop sharing and then move back towards the PowerPoint, if I can find it. There it is. Share it again. So we'll end very quickly with a few bits of discussion. So why does it matter if you identify your primary tumor? You can improve survival, you can target radiotherapy treatment, and you can also enter your patient into surgical trials such as PATHOS or the ECOG 3311 study, which closed, I think, last year, a couple of years ago. And if the primary tumor is not identified, you could argue that if they're HPV positive and you've sampled the entire oropharynx, then you can tailor any further treatment to the neck disease alone and avoid irradiating the upper airway digestive tract. You'll need to convince your oncologist about that, and we can discuss that later. So for example, if they have low volume neck disease, I mean, this was in old money, AJCC7, but if they've got low volume neck disease, then you may decide to just survey them, without giving them adjuvant therapy. I'll quickly end with our experience at St. George's. I started having spent time with Suren Krishnan in Adelaide, where they were doing a similar thing, and we published this paper in a small number of patients, and we found that we were picking up primaries in patients that were otherwise unknown in about 71% of patients. So we've done a bit of work over the last 4 or 5 years and published this recently in the Annals of the Royal College of Surgeons, where we had 28 patients in that study period. And we wanted to basically see how well we were at detecting these tumors. The demographics compared to the 2019 systematic review was kind of similar. We had more HPV positive or P16 positive patients. Our hemorrhage rate seemed to be a little bit higher. I do think there's a bit of underreporting that's going on there, but we can discuss that later. Otherwise, the data was fairly 28 patients. We put them through our unknown primary protocol, which includes a base of tongue mucosectomy, and we found that there was a synchronous disease in 3 patients who had base of tongue and tonsil SCCs, and overall the detection rate, i.e. in those with a base of tongue or base of tongue plus tonsil, was around about 63%, is what we were detecting. So these were patients who would otherwise have been classed as unknown. And then if you now look at the detail according to P16 status, this was quite interesting. Essentially, if they were P16 negative, I think we had about 6 patients, we never found anything in the oropharynx. However, if they were P16 positive in their neck disease, we were picking up to 80% in the base of tongue. And if you include the base of tongue and tonsils, it was 86%. So quite a high pickup rate in the P16 positive patients. So it does raise the question as to whether or not we should put patients through this procedure if they are P16 negative. So consequently, that's our protocol. If they've got metastatic SCC in the neck node, or we request P16 testing, which we're able to do on cytology. We get an MRI CT first, or CT first, and if there's no primary, we get a PET. If all the imaging is negative, we basically put them through a base of tongue mucosectomy at the same time, and then make a decision as to what to do with them afterwards. And in terms of complications, it is very painful. It's more painful than a palatine tonsillectomy. So we discharge all our patients on opioid analgesia and steroids. And as I said, we do get some bleeds afterwards. Most of them settle with conservative measures, but sadly patients can die from these bleeds. And you can get tumors that are very small. I mean, this is just an example of one of this P16 staining. The tumors are as small as 2.5 millimeters. This was one patient who had a 4 millimeter tumor in his base of tongue. As you can see, you look down the endoscope, you know, where do you, if you had to biopsy this tongue base, where would you start and where would you stop? I mean, you might argue that there's something subtle going on over there potentially, but that tumor was tiny. In terms of operating time, we've managed to get it down to under 40 minutes, and that includes both docking and access. So in terms of positioning your gag, docking the robot and the resection, you can do all of this in less than an hour. And that just shows you what the setup looks like. And we have, and you get a nice, good specimen like that. So should you do it separately or at the same time? I think there's a cost benefit to doing it together, and most patients do like it as well, having everything done at the same time. So in summary, TORS-based tongue mucosectomy, it definitely improves the detection rates of primary tumors that would otherwise have gone undetected with conventional techniques. I think we do need to pool our resources and do a bit more research to confirm that the additional expense, you know, justifies the presumed reduction in morbidity from targeted radiotherapy treatment, but it kind of seems obvious. It does mean we can offer patients, you know, surgery as a primary treatment modality. And I think when, you know, studies like ECOG 3311, you know, finally published in Pathos, that's probably the way we'll go. And it also means we can put our patients in trials such as MOSES, and I'll end with the MOSES trial, which is a UK study looking at whether or not step serial sectioning compared to conventional histology improves the detection of primary site in tonsillectomy and tongue-based mucosectomy specimens. And they doing some secondary outcomes, looking at functional recovery, for example. That's the eligibility criteria. It's a UK multi-center study. Just to give you ideas, if you want to do similar things internationally, it's being led by Professor Vin Polari and John Hardman, or his fellow. There are currently 9 centers open. We're hoping to join them at St. George's pretty soon. COVID kind of got in the way of things earlier this year. And these are all the various sites that I think are currently signed up. So on that note, I should end. Thank you very much.
Thank you, Mr. Ofo. It was a superb talk. There are a few questions. The one is by Dr. Kiran. He says, can charring during the dissection cause, I think basically, would you miss out any tiny tumor when there's a lot of charring in the tongue base when you're doing a tongue-based mucosectomy?
That's a good question. We picked up tumors as small as 2 millimeters. So we've not really found that to be a problem. You know, I think you're giving the pathologist such a big specimen. Our pathologists absolutely love us because, you know, when we do tongue-based biopsies, we just give them tiny little chunks, you know, tiny pieces. But with a tongue-based mucosectomy, they have a great big piece of tissue. And I suppose the challenge now is making sure that the pathology techniques are actually robust enough to pick up these small tumors, because not every pathologist will sample the entire piece of tissue. And that's why the step serial sectioning study, for example, is important.
Something like the sentinel lymph node where you step serial section the node. Okay.
Correct, exactly.
The next question is by Dr. Abhijit Singh. He says, how dependent are we on our pathologists for microsectioning and IHC of the whole specimen of bilateral tonsillectomy and tongue-based mucosectomy to identify a tiny primary, because this will create more than 100 slides with regarding step serial sectioning?
Yeah, so good question again. It is a lot more work. Well, I suppose we have to ask ourselves, what's the added value? So depending on what bit of the literature you read, you know, you're getting anywhere from 60 to 80% pickup rates with sort of conventional techniques. So you could argue that, you know, maybe the process, the protocol might be to, go with your standard techniques, and then if you don't pick something up, then do step 0 sectioning. That's probably one way to go until the data from trials like the Moses study comes out.
Maybe you think even the PET would kind of direct you to the site too, because if there's a little bit of a uptake, you feel, with that help?
I've not found, but we've had tumors as big as 3 centimeters that have not lit up on PET. I mean, that's another bit of work as well that we're looking at, whether or not there's something to do with the FDG, receptors that we could look at in those subgroup of patients.
Okay. And there's Dr. Jagannath Dixit. He's asking, do you add with other site biopsy from pyriform fossa, fossa rosemilla? I think when you do the pan endoscopy, he says, do you also do the 6-site biopsy?
No, so we don't. So our protocol is, if we've done so first of all, if they've had a thorough clinical examination by a senior head and neck clinician, and at the time of pan endoscopy, we always use a 0-degree Hopkins rod, so that we can inspect every square centimeter of the upper air digestive tract. If there's nothing obvious in the piriform fossa or the nasopharynx, we will not do blind biopsies.
So this is done in the clinic, and the pan endoscopy becomes a bit redundant. Would you say that, or?
Well, no, the pan endoscopy is still useful because we still incorporate, but we normally have a good feeling from the clinic. But the pan endoscopy just allows us to get into the piriform, the apex of the piriform fossa, which is not as easy to assess, in the clinic.
Okay. Then how is I think swallowing difficulty? Does any of the patients have dysphagia post tongue-based mucosectomy? I think that's what Dr. Matthews
So swallowing function, so we don't put any nasogastric tubes into any of our patients. They all go home within about 24 hours. The ones that you need to worry about, and we've learned the hard way, are patients with pre-existing cognitive decline. And sometimes that is not immediately apparent. So we had an elderly lady, you may remember from the figures, there was a patient with an adenocarcinoma of the lung that it turned out to be. She had a tongue-based mucosectomy and a neck dissection. She didn't swallow again. And we later found out that basically she had underlying dementia, which wasn't evident to us as surgeons, I have to say, preoperatively.
So I guess I think the performance status or preoperative assessment for history of Parkinson's or dementia would help.
Correct.
There's another question just popped up by Dr. Rajiv Sharan. He says, if mucosectomy is positive, do you go again and resect to avoid radiation if only one single node is positive?
Yeah, so yes. So short answer is yes. Yeah, because essentially we've done a biopsy, we've identified the primary site. Because with the videos from your TORS resection, you know the boundaries of your previous resection. You just need to then go back and do a compartmentalized resection of the tongue base and the neck dissection. And as I said, you can enter those patients.
I guess the same
clinical trials.
I guess the same applies for tonsillectomy too. If the tonsil comes positive, then you go back and take a superior constrictor.
We go back and do a lateral oropharyngectomy.
Okay. And the role of frozen section in assessment of a likely tumor, would you do?
Again, it's all about, I suppose, you have to plan your operating lists. We feel that we would much rather wait for the pathologist to look at the entire specimen and report back. And then within a short space of time, we can always take that patient back to theatre to do a definitive, oncological resection if required. So depending on how busy our pathologists are very busy. They complain if we send them frozen sections. So if your pathologist is sitting around, has got plenty of time, you could incorporate that into your practice by all means.
So there's no more questions, but I would like to get Professor Paleri's point on this, because I know you mentioned he may have data on this, as Dr. Duwari has mentioned. Mr. Paleri, do you have any points to add to on this topic before we go over?
No, not particularly. Really good talk, and I quite enjoyed that. I'm hoping the Moses data, when it rolls out later in 2021, we expect the full data set to arrive 2021. will throw more light on this. And don't forget John Almeida's FIND trial. So that's going on too. So you'll have two sets of data coming in, which will inform us better to manage the unknown primary in the setting. In regard to the question on multiple sections, you can't do it in routine practice. It has to be done within a funded trial. And that's the only way to do it. And the reason why we're doing it is not, we aren't stopping it if we find a primary site on conventional pathology. We're using the entire bilateral tonsil and the tongue-based mucosectomy specimen through putting it through a 500 micron sectioning, irrespective of whether a primary is found on conventional sectioning or not. So it'll answer the question of multifocal primary sites, which has been published. And if we have this, and we're hoping for 90 patients to be recruited. If we have it in a 90 patient cohort across multiple centers, including collection of morbidity data and recovery data, that would be a reasonable piece of work to inform further practice. And of course, generate the next relevant research question in this setting.
Is there a role of molecular markers in this setting? Do you think the future would hold any role of molecular markers to instead of doing the serial sectioning?
So we're not working on molecular markers. We're working on rapid evaporative ionization mass spectrometry, where you suck out the smoke at the time of the procedure and then put it through a mass spec machine. So that can be potentially adapted to the unknown primary setting. We now have ethical approval purely to work on it in a recurrent cancer setting. It's certainly extendable into the unknown primary, but I have no data on that.
We saw the Oracle cancer talk. That's why I asked you that question now. Okay, so thank you.
Can I ask you a quick question? Vidya, sorry to interrupt.
Sure.
Oh, I think you had some retrospective data when you were at Newcastle, which sort of informed the Moses. But what was your initial,
yes.
what is, I should say, your initial gut feeling about that question of serial step sectioning versus conventional pathology with the entire specimen submitted for improving the detection of the unknown primary?
So that was a 13. What a memory! I must congratulate you on your memory, despite passing years.
Hurtful,
so that
hurtful.
So that was a 13% uplift from conventional sectioning. So once they did the conventional sectioning, and then parked the information, went back to those patients who already had an unknown primary or a known primary irrespective, and then performed step serial sectioning. So this was the NIDAS, this was the pilot information to get the grant money for the Moses trial. It was a 13% uplift. So assuming that with conventional sectioning, you're getting a 70% hit rate, then you add step serial sectioning, you might take it to 80, 85%.
Thank you.
Wonderful talk, NEA.
Thank you, Michelle. For
good talk, NEA.
I just have one more question before I did notice less charring in the SI compared to the XI. Does the robot make a difference, or is it just the operator?
I think it's probably the operator, to be honest with you.
Thank you, Mr. Ofu. So we'll now move on to the next talk. That would be by Dr. John D. Almeida. He'll be talking on robotic reconstruction of the oropharynx, concepts and technique.
Thanks, Vidya. I want to start by just sort of echoing what some of the others have said about, thank you for inviting me to be part of this meeting. It's really great to see some familiar faces, but also to meet some new people, at least virtually. And so far, the program has been absolutely wonderful and informative. Can you all see my slides?
Yes, we can.
Okay. Let me just get into the slideshow mode here. So what Vidya asked me to talk about is a little bit about reconstruction after oropharyngeal defects created by TORS. This is an area of interest that I developed when I was a fellow at Mount Sinai in 2011, but I've continued to adopt in terms of managing particularly sort of larger volume TORS resections. And just in terms of what we'd like to talk about, obviously, we are creating potential beds for complications, both surgical and non-surgical, but also creating potential functional impairments for our patients. So we do have to think about reconstruction in terms of mitigating both complications and functional impairments. I want to talk a little bit about a defect-based classification system that we created some time ago that I continue to use in terms of thinking about when and where and how to reconstruct these defects. We'll talk about little tidbits and pearls, different options for reconstruction when needed, and also a little bit about outcomes. And there's not a heck of a lot of data out there. I'll be the first to acknowledge that. I think, you know, prior to sort of the advent of TORS surgery, or pharyngectomies were performed by open approaches, and we all know what kinds of complications they had, significant wound complications with fistulas, microvascular flap failures, vessel rupture, and functional impairments. And if you think about TORS, you know, in many ways, we still have these potential complications and functional impairments, maybe to a lot lesser a degree. Really why the pendulum swung away from these open surgeries is that the amount of wound complications were really unacceptably high. And the amount of functional impairment was unacceptably high. And in the early 2000s, there was really a nice systematic review out of the Florida group that led the way for swinging that pendulum away from surgery towards chemoradiation. So as we think about swinging the pendulum back towards surgical approaches, we really want to minimize wound complications and functional impairments, and reconstruction is the way to go. So I'll just skip ahead. What are the complications we expect? You know, I don't have to explain to this audience. It's not unseen to see a patient come back after a TORS surgery with a wound infection, perhaps a neck infection. And often this is unidentified pharyngocervical communications at the time of surgery that haven't been appropriately closed and dealt with. And you know, we spoke a little bit about hemorrhages, and Dr. Dabas presented his nice sort of slides on reconstruction. I actually feel that reconstruction is a way to mitigate hemorrhage risk, particularly in the radiated patient. And we'll talk a little bit about how we can do that. Obviously, swallowing deficits and velopharyngeal insufficiency are known functional impairments that come with TORS surgery. And we'll talk a little bit about how we can mitigate that with reconstruction. So what are the things that we think about in terms of a defect and choosing a reconstruction? We think about the size of the defect, obviously the subsite of the defect. If it's soft palate, if there's a large volume of soft palate defect, that can be functionally crippling, particularly if you're taking the entire hemipalate up to the hard palate and soft palate junction. So thinking about ways to close the ipsilateral velopharyngeal port is important. I think the size of tongue base can also, the size of the tongue base defect can also affect your swallowing outcome, and we'll show you some data around that. Obviously, neck communication can predispose towards fistulas and neck infections, so we have to think about that. And vessel exposure is something that we really want to avoid because of those catastrophic significant bleeds. And that vessel exposure doesn't now, you know, have to really be the internal carotid. Often you will expose a lingual artery, and, you know, even with clips, there are portions of that artery that are exposed, and we have to think about coverage of any branch of the external. It doesn't have to just be the internal or the external in terms of vessel exposure. And the number of subsites. So we created a classification system called the CORD classification system, and we published this a long time ago. And really the ways to think about this are, does the patient after resection have any of these, what we call adverse features? So, you know, up to and including about 50% of the soft palate. Is there obvious neck communication with the primary site resection? Is there exposure of vessels? And as I said, it doesn't have to be the internal. Sometimes you can have aberrant externals that get exposed at the time of lateral pharyngectomy or pharyngectomy, or small branches off the external that need to be clipped and handled appropriately. So then we think about how many subsites are involved, you know, tonsil palate, tongue base. If there's one subsite, we call it a small defect with no adverse features. It's a class 1. If there's more than one subsite without any adverse features, we call it a class 2. And then we think about whether or not there's any of these adverse features, and then again divided into number of subsites. If there's adverse features such as palate, a large volume palate resection, it's a class 3. With more than one subsite, it's a class 4. And we use this, or at least I do, in terms of deciding when when to think about, larger volume reconstructions. And this isn't an absolute truth that, each one of these corresponds with secondary healing versus local versus, but it tends to be a continuum when you start to think of more and more about more complex reconstructions. And so this again just sort of summarizes that class 1 defect. I won't go into it. The class 2 defects, again, more than one subsite. And class 3 defects when you have either neck communication, exposure of the vessel, or greater than 50% of soft palate. And again, if you have any of those features with more than one subsite, it's a class 4 defect. So then we start to think about regional or free flaps. And I'm going to show you some video about how we've done that. This is a picture from Steve Kennedy's paper. Steve is a reconstructive surgeon in Philadelphia, and he works with Greg Weinstein and Bert O'Malley. And in the original series out of the UPenn group, they avoided cases like this where you have an internal carotid artery in the retropharynx behind a tumor. But they started in 2015 to start to actually consider resecting these patients. And obviously, you can think about after a resection, you have an exposed internal carotid artery. So based on your preoperative imaging, you really want to look at the location of that internal and external carotid artery. Is your resection going to expose either of those vessels? Because if it is, you want to potentially cover that, and that you can have the conversation with the patient in preoperative counseling based on the imaging that this is a likely scenario. Sometimes you'll actually be faced with scenarios where you are unanticipatedly looking at an exposed vessel or a communication, and you have to make some ad hoc decisions about how to reconstruct that patient. So obviously, thinking up the reconstructive ladder, the first thing we think about is primary closure. And this is a paper from the Korean group, from a Korean group talking about using primary closure. And you can see here, this is a post-TORS resection staring underneath the mandible. This is the digastric, and you're seeing an obvious communication. And what they do as the first step of that primary closure is they take any residual constrictor muscle and they sew it to the remnant tongue base. It's a 3-step closure. Then they take the mylohyoid and approximate it to the digastric. And the third thing they do is they bolster that closure and oversew it with the second layer. And they presented a series of 13 patients where they have obvious communications. And using this three-layer closure, they had no further fistulas in this small series. But it's a nice paper that talks about using primary closure methods. Now, I know Professor Polari has a big volume of experience with radiated patients, and we do this rarely in Toronto, but sometimes when we do it, I often feel that you can't quite leave a radiated bed much in the same way that you can a primary tumor bed. You have to cover that because these wound beds, they granulate for months. They have foul, malodorous, discharge with exudate that are painful. So I often consider putting some fresh tissue in there, and buccal fat is one option. And you can see how we do that. This is the post-TORS resection with the uvula. You make an incision, you can actually communicate it to the anterior aspect of your incision, make an incision, and you find the buccal fat and you keep it pedicled on one of the facial artery branches and you tease it out. I use 2 dental pledgets. I lift mucosal flaps up and down. And what you get is a nice a bed of fat. And again, it's pedicled on a facial artery, and you can rotate that in to cover the defect. And you suture the edges to sort of close that defect. And that really alleviates pain in that post-radiated patient, where if you don't cover that, that's a chronic non-healing wound in that patient. The PIT group and Uma and Megan Turner, who was, I believe, a fellow when she did this paper, along with, I believe, Eric Wong, who's a skull-based surgeon in Pittsburgh, talk about using a nasoseptal flap. And for those of you who have experience in endoscopic skull-based surgery, the nasoseptal flap is a nice flap taken from the nasal septum, pedicled off the posterior septal artery, and you have to create a small tunnel through the palate to bring that septal flap down. And you can see here it's tunneled through the palate in a cadaver, and there's a septal flap to cover the oropharyngeal defect. And this is in an actual patient. Here's the TORS resection bed, and you can see a flap covering part of the defect. I find that these flaps don't quite reach particularly to the lower extent, but they do provide a nice, again, vascularized covering to avoid those symptoms of pain, potential vessel exposure, and non-healing wound. Again, this is from the PIT group. I use this flap very frequently, the FAM flap. It's a nice flap. You can use it inferiorly or superiorly based, depending on your defect. And this is an inverted view. You can lift this, always lift this deep to the buccinator. You identify your facial artery on the deep surface. You ligate either the superior aspect if it's an inferiorly based flap, or the inferior aspect if it's a superiorly based flap, and you pivot it over. It's good for palatal reconstruction, and it's very nice to reconstruct the superior aspect of the defect. And this is some pictures taken from Uma's group where they've used a FAM flap, and it's a very nice flap along with buccal fat in terms of local options. I really like this flap, the sternocleidomastoid flap, particularly for pharyngocervical communications. I find it to be quite nice to pack off that defect. This is one lifted. I've moved away from doing it in this way. This is one in which I've taken both it's a superiorly based SCM flap. You can see the spinal accessory nerve coming in there. This is the sternal and clavicular heads. Now I just use the sternal head to avoid that contour defect. If you take both heads, you take just the sternal head, preserve the accessory insertion, and you do this superiorly based. You come to about the mid-level of the sternocleidomastoid muscle, and you rotate that superiorly based SCM flap. Obviously, you have to find your hypoglossal nerve. You divide you clip your lingual artery, and you want to get this muscle actually deep to the external carotid. Here you can see us dissecting out the the hypoglossal carotid. You want this muscle to come underneath that to create a separation from the external internal complex from the pharyngotomy, and there's a submandibular gland. And in this case, I used a GIA stapler, but all you need is a monopolar, and you get that muscle tucked in. It closes that defect quite nicely. And in using this flap, I very rarely had any issues with fistulas, particularly if you have a defect. And there it is, kind of sewn in there and secured. This is a nice paper out of an Indian group, and they classified their defects using the CORD classification system that we spoke about, and used SCM for 42 patients with a variety of defects, including more advanced defects with those exposed vessels or multi-site exposed vessels. And what they found is, sorry, my slides are not advancing. That in that 42 patients, they had only 3 fistulas, despite all of them having, some degree, or many of them having some degree of advanced features, and 3 patients developed hemorrhage. And so they report that was one of the few reconstructive studies done for TORS that have actually reported on outcomes, which was nice. So microvascular free flaps, sometimes I will use these particularly for larger volume resections and reconstructions. You can actually inset them, as Dr. Dabas showed with the robot, particularly on the superior aspect. I'll show you some video of how we inset the inferior aspect. These pictures are taken from one of Dr. Polari's papers on reconstruction. And these are instruments they use, the black diamond microforceps and the pot scissors. I find that 2 needle drivers when you're doing inset is all you really need. You can find them on the 5mm arms or 8mm arms. Or if you don't want to change instruments, keep in mind that these instruments aren't cheap. And if you're using a Maryland, you can even do this with 2 Maryland forceps, one to hold the driver and the other to tie with. So if you don't want to change instrument and avoid usages, that's a quick trick to do that. So this is a patient with a fairly advanced tonsil tumor that which ended up having a pretty significant pharyngeal communication. And you can see that here we are taking out the constrictor muscle. You can see it going down to the epiglottis. We chose to use a submental flap here. Submental flap is pedicle on the submental artery and vein. You can divide the superior aspect of the artery and vein as it crosses the mandible. And here we are insetting it again You do the bottom part transcervically because it's very easy to do. It's very hard to get those sutures in with the robot lower down in the inferior aspect of it. And the superior part you can inset sort of transorally with the robot. And again, you can use, you can see we have 2 needle drivers here, and that flap is inset quite nicely. So that's a great option in terms of regional flaps. And again, that it would be no different in terms of putting a radial forearm or anterolateral thigh flap. We would do a similar sort of inset. Now, this is a paper that one of my colleagues at Princess Margaret, Doug Chapea, published on template-based reconstruction. And I really like this. I often use sort of a variation of these templates to consider reconstruction of defects. And you can see what he's done here. This would be a left-sided pharyngectomy defect. A tab for the soft palate, one for the tonsil, one to cover the tongue base, one to cover the buccal aspect or the retromolar trigone. Often if your defect is this big and you're thinking about a flap, templates are very important. These are very complex 3-dimensional defects, particularly if you're going from palate to buccal to tongue base, and you want to think about this before you just throw up a piece of meat in there, because often, you know, if you're not thinking adequately about it, you'll come up short in terms of how much tissue you're putting in there. And you don't want to put in too much tissue because the converse is too much bulk in there can impair their swallowing. So you want to get the measurements quite right. And I now use templates for this area, particularly for more challenging defects. This is some data from our original series. We looked at 92 patients with a variety of different defects. And what we looked at is, you can see we looked at outcomes with the MDADI and a velopharyngeal insufficiency questionnaire. You can see that the bigger the defect, obviously you're going to get sort of, you know, decreased swallowing outcomes, and that is inherent with what we do. It's not statistically significant, particularly because there is a small sample size in this cohort, but there was a trend towards sort of reduction in swallowing outcomes. What we did find probably the biggest predictor of swallowing outcomes, and there were some comments on Orator, and this is probably the biggest predictor of swallowing outcomes, and I think the vast majority of people can appreciate this, is if people do have radiation or chemoradiation after surgery, your swallowing outcomes go down. And in Orator, where we see that difference, what's really hard to tease out is the subgroups of these patients that have had adjuvant therapy, because they're only about 13, 13, 13, about a third in that subgroup. So this is, to me, is probably the biggest predictor of poor swallowing. Velopharyngeal insufficiency scores, we didn't see much of a difference between the different classes. When we did a multivariate analysis on these 92 patients, we found that adjuvant was the only predictor, not defect size, on swallowing outcome, and there were no predictors on velopharyngeal outcome. Getting back to tongue-based defect size, the larger the defect size, the poorer the swallowing outcome. That comes as no surprise, particularly because of aspiration. I've moved away from putting free flaps for tongue-based resections, obviously because you're putting insensate mucosa there. You let that bed granulate, and I find they swallow much better. This is just to sort of close out, this is a study from the Edmonton group that looked at free flap reconstruction for TORS defects versus mandibulotomy defects. They had about 18 in each group in the TORS defect, a larger volume in the mandibulotomy group, but they did some matching algorithm to match them. TORS with flap versus mandibulotomy with flap, 18 versus 29 patients. And it took them actually a significant amount of time. We don't, in Toronto, it doesn't take us this amount, but their cases went 15 hours. We're usually done in about 8 or 9 hours. Length of stay was significantly improved with TORS versus mandibulotomy, probably because of the avoidance of some other complications. So they showed that there was a significant difference there. They also compared complications, and you can see fewer complications in the TORS with free flap versus mandibulotomy with free flap. Some differences in the amount of blood that was required, neck infection, and so on. And they also compared the cost. There was a smaller amount of cost for TORS with free flap versus mandibulotomy with free flap. So we'll kind of summarize right at this point. Classifying defects, I find, is helpful to think about the pieces of the puzzle that need to be reconstructed and whether or not you should consider reconstruction. Goals of reconstruction are to mitigate complications, and obviously we want to maximize outcomes for our patients where possible. And we do have several tools in our armamentarium, but we should be thinking about, again, what we don't want to do is to create big defects and have lots of complications and functional outcome impairments, because we should learn from our history, and those who haven't learned from their history are doomed to repeat it, I believe was once said. So this is the reason why mandibulotomy and open oropharyngectomies fell by the wayside. So we should make sure that we think about that moving forward. And with that, I'll stop. And thanks once again to the meeting organizers for a great meeting.
Thank you, Dr. Almeida. It was such a superb technical talk. I just ask you some questions. One is from Dr. Mudit Agarwal. He says, how did you manage hair growth with the submental flap? I think he's meaning in terms of post-radiation reconstruction.
Sorry, can you repeat that? I didn't hear that.
How did you manage hair growth with the submental flap? I mean, I think the submental flap, the hair growing.
The word before submental flap. How did I manage which part? I didn't.
The hair growing.
Oh, I see. No. I mean, obviously that was in a woman, so it wasn't a problem. But yeah, that can be a problem, particularly in men. You're transplanting the beard into that location. But regardless of the flap you use, in some men there are no parts of the body that aren't hair growing. But what I will do is I bring them back to the clinic, and it's very hard to get a laser in there, but I'll use a needle tip cautery and de-epilate the areas that I can see transorally, and that often reduces the amount of hair growth in that area.
Thank you. I just want to ask you a question. I'm of the thought that if the volume of the oropharynx is large, then the patient is going to have significant dysphagia. That is, if you put a large insensate flap filling up the defect, forget the existing musculature. So do you think, from your point of view, you're telling about the pieces of the puzzle or the template flaps. So, try to put back pieces of the puzzle together. That reduces the volume of the oropharynx. And would that help in the dysphagia?
Yeah, I think so. I think part of that is choosing the right consistency of donor site. If you have a thick thigh, or if you're using flaps from the back, from the latissimus thoracodorsal system, those can be quite bulky. And often they can obliterate the pharynx and really cause difficulties with swallowing. And you have to keep the trachs in for longer if you are tracheotomizing the patient. So that's something where we try to get away from. We try to choose the right consistency of tissue, and that's usually either submental or radial forearm flap for the most part, unless it's a person with a very thin thigh. I try to stay away from the anterolateral thigh option.
Okay, so the days of putting up a bulky flap just to make a wall, that thought is gone now. So it's you classify the defect, make a template, and do the reconstruction accordingly. I know that Dr. Douglas Shepard had the same paper for radial forearm flap for the tongue. He had a template for the lateral or oral tongue, because when I was there at the time, they used to, I remember talking about that. But from what I gather from this talk is before you plan for the surgery, you start figuring out what the defect will be, classify it, and then work on your reconstruction. So you're doing a retrospective, or you're working backwards, basically.
Right. And sometimes, as I said, what you see after you've done your resection is a little bit different than what you would have planned. So you have to sort of be able to sort of pivot in that case.
And two more questions. The nasoseptal flap, when you tunnel it between the soft palate and the hard? Do you make a hole and tunnel, or how does how do you make it?
Yeah, I presented that just sort of out of interest. I haven't used that myself. I've used buckle and fan flaps because I find they rotate in quite nicely. I think the nasoseptal flap, to me, one of the challenges, and I do some endoscopic skull-based surgery, but I find that flap, you have to switch instrumentation. and then create the tunnel. It makes things a little bit more complicated. Maybe you might want to see if Uma has some experience with that. I've not done it myself, but I can imagine that if you've got a bit of a palatal defect, that a lot of that is already ready and set up for you to go. If you've taken your tonsil up to the palate, most of the time that probably is just ready to sort of just drop in there.
And Dr. Riveri, do you want to add anything?
Yeah, I think I could be unmuted. Yes, so the nasoseptal flap is really, in our hands, reserved for the patients who you think have a pretty large defect and you need a really thin, pliable piece of tissue. As Dr. Dalvera said, you don't want to put a anterolateral thigh if they have a very thick thigh. If you need to cover a fairly large portion of the mucosa, then it's also difficult to do that with the fat flap, which you showed. That's also really, really good, handy technique. So we've used a nasoseptal in those cases. So you get a really long flap, basically. And then to improve the length of it, we do make an incision at the hard palate, soft palate junction, deliver the flap through that incision almost as a transposition or interpolation flap, and then we come back at a second stage if it has not atrophied sufficiently to make a small cut and divide it. So that is really just another tool in the armamentarium to have. But as John points out, it is much more complicated.
Mm-hmm. Have you ever had any experience of, has either of you ever had any experience regarding the islanded FAM or the islanded nasolabial flaps? Do you think that would reach anywhere into the oropharynx? Like how you tunnel a submental, an islanded nasolabial or an islanded FAM? Because
yeah, we've done the islanded nasolabial flaps. I actually just did one to cover a defect of the oropharynx, but it wasn't for a TORS case. It was for a traditional, transoral resection of an RMT tumor. So yes, those are very nice flaps. You can use them. You don't necessarily, it's nice to have them just in case you need it.
Because
I saw a note here also from Mudit about the supraclavicular flap. All of these are good options, and you have to use them in the appropriate patients. In our hands, the supraclav flap tends to be a little bit less, I would say, reliable because of the reach. Mm-hmm. So if you're trying to get all the way to the oropharynx, you might be pulling on it a little bit more than you would like. And again, in our hands, these would be reserved in the cases, as Dr. Dalmeda said, for patients with salvage surgery.
Okay. And one more question, John, is regarding the, I'm sorry, I'm coming back to the orator trial again, is regarding, did the patients who had reconstruction in the orator trial, was that a difference in different flaps, or is just a standardized flaps? I'm sorry about Dr. Almeida?
Sorry, I was muted there, Vidya. Sorry about that. Yeah. So the orator trial was basically T1, T2 inclusion criteria. None of them really had any significant reconstruction. Most of them were left to granulate. Probably best case scenario, I know I put a couple on where I would just, put a small SCM flap in there. But there was that reconstruction component wasn't even collected in these CRFs, the case report forms. So, and nor do I think there was any large volume of patients enough to do a subgroup analysis. But for the most part, they were very straightforward defects that were left to heal secondarily.
Sure. Thank you. So we'll now go on to the next talk. That will be Dr. Riveri. But before we go, Dr. Almeida, it'll be great if you're there for next Sunday too, because we'll be talking about oropharyngeal malignancies. And since you're involved in the orator trial, it'll be great to give your inputs too, if you are able to log on next Sunday, that's the 26th.
Absolutely.
Thanks. We will now go to Dr. Riveri's talk. He has two talks. One is the first talk is safety and considerations, prevention and management of complications for triangulation. Zoom platform is yours.
Okay, thank you. I'm going to switch over here to the I think you guys can all see my screen here.
Yeah, we can see the screen.
Yeah. So I've taken the liberty of changing the title just a little bit of the talk to prevention of bleeding, because the rest of the topics are all very, very important. I think dysphagia, et cetera, has been covered to some extent by our panelists.
For your foot, how's your foot? Huh?
So we will carry on with this sort of idea of bleeding.
You didn't have much pain.
Hold on, I will just have to mute someone else. So, yep, I think they muted. Go ahead. Thanks.
Okay. So this idea of complications, it's very important. I'm focusing here on bleeding because I think that is sort of the most important complication that we worry about. When I give this lecture, I often get asked about the technique that's used to perform the surgery, whether it makes a difference if you use the robot or the laser, etc. For transoral surgery, I do not think that this is really pertinent. I don't think this is really about the technique as much as it is about the operation that's being performed. And to that end, I would say that the caveat on that is that when you use a surgical robot to perform these operations, the improved visualization access, which is the reason that we like this technique, this transoral robotic technology, because it gives you this wristed technology with the Da Vinci platform, allows you to have access to areas that are not generally encountered while doing transoral laser surgery, for example, or transoral surgery with a headlight and cautery. And so as we think about, therefore, bleeding, so when you go to places that you typically don't go to and venture into, you have the risk of bleeding in these areas. And so we have some of these most feared complications, which include bleeding, which is intraoperative, and postoperative in two categorizations. Intraoperative bleeding, of course, is quite devastating because it raises significant panic for the surgeons as they're performing the procedure. Postoperative bleeding raises much more concern from a preservation of life perspective, since the bleeding can occur at unexpected times. And if the patient is not in the hospital when this happens, then the ability to control this also becomes a bit of a problem. So as in all things, avoidance is the preferred method of dealing with these complications. And this, the ability to maintain and control these complications is related to the surgeon's experience, whether it's intraoperatively or postoperatively. And so, as we heard before, that the unit that had done several cases in India has not had any bleeding. That sort of makes me feel really, really good that the data that had been shared in the past from the experiences of the people that have sort of done a bit more of the robotics up front, for example, in the order trial or the ECOG 3311 trial that I was a part of, we were able to advocate for certain methods to control bleeding based on data. And I hope that has now moved forward and is saving morbidity for future patients. So there are not many studies that address bleeding and hemorrhage specifically after TORS. There's much more data in regard to transoral laser surgery or TOLM. There may be a difference between these methods in terms of the bleeding, but again, I don't think that difference is statistically significant or that important, but we'll go over these briefly. So one of the largest studies that has been published was a slightly older one now, 2013, from Poli et al. This is a retrospective review of nearly 1,000 cases treated with transoral surgery. Clearly, because it was performed in 2013, the number of patients having transoral robotic surgery was relatively small. TOLM, or transoral surgery with a headlight and a cautery, was more common. Postoperative hemorrhage was the object of investigation of this particular paper, and they looked at postoperative hemorrhage in these patients, and they broke them down to three categories: minor, major, and severe, defined by the extent of bleeding. To summarize this paper, postoperative bleeding occurred in approximately 5% of cases. 2/3 of this 5% required operative intervention, so the patients had to return to the theater for intervention. Luckily, only 1% of cases were considered as severe bleeding. Now, in these patients, transcervical ligation of the external carotid system was performed in approximately 15% of patients, and these authors did not see a significant impact of reduction of bleeding rate or severity when patients had transcervical ligation of the internal carotid system, that is the external carotid artery at the main, was ligated just after the bifurcation, and there was no impact of that on bleeding or severity. And there was also no difference between whether the procedure performs robotic or laser surgery, although the robotic numbers were really quite small. Scott Magnuson, when he was at the University of Alabama, also looked at this in some of the earlier data sets, looking at volume versus surgeon experience. And what he did was he mapped out bleeding, which is shown in these squares. So this is the number of complications defined by the different groups. So this is groups 1 through 4 were broken on the first 40, the second 40, the third 40, and then the fourth 40. So basically 40, 80, 120, and 160. So in the first group, in the first 40 cases that were done there, you can see there was about 7 out of the 40 patients had some bleeding complications. They learned from this, and in the second group, this number dropped down to just 1 out of the 40, but then it sort of rebounded a little bit, probably as the surgeons gained experience and maybe gained a little bit more comfort in doing these operations. But nonetheless, you can see that there is a trend towards decreasing complications with increasing experience. And so that was this paper published by Asher, was the first author, and Scott was at Alabama. And so you can see that there was, again, on the whole, about a 7% bleeding rate for these patients. And again, a significant number, 6% required reoperation. The average time to bleed was about 8 days. So again, this is not dissimilar to a transoral, a simple tonsillectomy that you might perform, where bleeding happens about 1 week after the surgery is completed. So we had a devastating complication at Pittsburgh. Luckily, nobody died, but we did. I had a pretty significant bleeding event, and so this was back around 2013 timeframe. And so I decided that it was important to go back to the laboratory and have a look at the anatomy and better understand the anatomy, because I felt at the time that my individual knowledge of the anatomy for this subset was not so clear. And I'm sorry that I wasn't able to log on for the other session. Unfortunately, it was the time difference was too inconvenient for me. But I know that Vidya, you and others have talked about the anatomy of this area. So indulge me for just a few minutes as I show some of the surgical anatomy that we've done in the laboratory. And so this work was performed by a very, very talented postdoctoral fellow that I had in the laboratory, who's a microvascular surgeon from China, Dr. Chenying Wang, who's now back in China at the China-Japan Friendship Hospital in Beijing. And so we had some cadaveric heads which were injected, and then we performed this kind of dissection to really demonstrate the anatomy of the parapharyngeal space. So for example, this is a dissection and a picture taken externally of the left side of the cervical anatomy from the parapharyngeal space, demonstrating the styloid with the styloglossus and stylopharyngeus muscles, the digastric, and the internal jugular vein shown here injected in blue for blue latex, and then the anatomy of the external carotid system. And we'll go into this a little bit in detail in the rest of the lecture. And so if we look at this anatomy, this is now again a transoral view, looking at the right side of the oropharynx. Here's the uvula. We went back to the lab, used some cadavers, and then performed a careful methodical dissection of this lateral oropharynx. So we removed the mucosa at first, then we removed the next layer, which is to remove the muscles, the constrictor muscles. We then see the styloglossus muscle here. So the styloglossus and stylopharyngeus form what's called the stylodiaphragm. And if we remain lateral to the stylodiaphragm, you'll be free of these major blood vessels that you can injure, including the external carotid. And so not understanding that stylodiaphragm is a critical pitfall in some of these dissections. And again, as you tackle bigger tumors, as Dr. Dabas has elegantly shown, you really have to understand where these muscles are and what the muscles represent. This is, in my opinion, not dissimilar to the posterior belly of the digastric while doing a neck dissection. Sure, you can resect it if necessary, but when you resect that muscle, you have to understand that the great vessels are now immediately deep to you, that the 11th nerve and the 12th nerve and other critical structures are immediately now accessible, which they would not have been had you preserved the posterior belly of the digastric. So this styloglossus and stylopharyngeus muscles are very similar to that. Now, if you're resecting the tongue base, you have to transect some of the styloglossus and stylopharyngeal muscles to obtain a margin. And if you transect them more inferiorly towards the attachments, then that is a slightly safer plane to be doing the dissection. Now, if you were to remove these muscles completely and look at this area, you'll see now the parapharyngeal fat. This is the pterygoid muscles. And you'll start encountering the venous plexus, which drains the lateral oropharynx. And these veins eventually will traverse inferiorly to drain into the Ranine veins, which are the venous plexus that lies on top of the 12th cranial nerve, which we are all quite familiar with doing a neck dissection. And we all know what the flow is in that system. So it's a very, very high flow system. And so to that end, if we do not have to control these veins, then it makes it that much easier. If you do have to encounter these veins and control them, you need to do so with great care and with ligation, with clips or harmonic or whatever technology you wish to use, smart energy, to be able to control this, because these veins will drain and it's a relatively high flow system. And so much of the bleeding that happens in patients after TOR surgery is arterial. That's what we fear. But also venous bleeding can also be quite important, and you have to be careful that you don't ignore that aspect of it as well. So once we traverse these veins and we've sort of cut some of them and reflected them, then you encounter the lingual, the facial, and the ascending pharyngeal arteries from the external carotid system. And if you're not careful and you don't understand how far down you traverse laterally, you can encounter the external carotid system and actually have massive hemorrhage from this. And you can actually see these transorally if you're not careful. And so this is just a point to bear. So again, very briefly, here's a quick sort of a video. It's just about a 1-minute video showing that same anatomy, but now performed in sort of a video fashion. So again, we're taking off initially the mucosa. Then you can see these muscle fibers. I apologize that this is a cadaveric head, and so you may not be able to see quite the same color that you would in vivo in a live patient, but nonetheless, this is sort of the oropharyngectomy performed. Here's a small branch of the ascending palatine artery, so not the ascending pharyngeal, but palatine artery comes off the external carotid system. That's typically what is controlled. It's a small, a very small artery, about 3 millimeters in size. And all of this work has been published in Clinical Anatomy, so you can see these videos and this dissection as well. So here you can see the nice bifurcations of the external carotid system transorally. Here's a styloid process. So again, the parapharyngeal space, the pre-style parapharyngeal space is sort of up higher, and this is the lower portion of that parapharyngeal space towards the level of the hyoid bone. So you have more space, anatomical and surgical space, as you do these dissections inferiorly versus superiorly. So the styloglossus and stylopharyngeal muscles are the key landmarks. They delineate the vascular anatomy. They form what's called the stylodiaphragm, and having the stylodiaphragm be in place is a good way to avoid encountering the vascular structures which all exist lateral to the plane of the stylodiaphragm. So again, looking at this in a more of a cadaveric model, this is a external view of the left neck, which has been dissected. So this is going medially, this is laterally, this is the sternocleidomastoid muscle. This is the cut end of the digastric. So digastric posterior belly would be running in this direction. So once you've cut this digastric muscle, of course, you will see the internal jugular vein. You'll see the carotid artery. Here's the hypoglossal nerve running down towards the tongue. This is the glossopharyngeal nerve, this thin structure. And you'll see here from the styloid, the stylopharyngeus and styloglossus muscles. So styloglossus goes more anteriorly, stylopharyngeus is a bit more posteriorly. And penetrating the stylodiaphragm is this ascending palatine artery. Ascending palatine, not to be confused with the ascending pharyngeal, which is a branch directly from the external carotid. Now, this ascending palatine artery can come from the lingual, the facial, or the external carotid, depending on the anatomy. This is the same cadaver now seen in an intraoral view with the Da Vinci platform. We can see again the styloglossus muscle, the stylopharyngeus muscle, the ascending palatine penetrating this diaphragm, and the glossopharyngeal nerve, the external carotid, and the submandibular gland, of course, would be more anterior and inferior in this view. Here's the uvula. So again, looking at the left oropharynx. Now looking at the right side, again, the same sort of anatomy. The uvula would be here. We've dissected through the lateral pharynx. Here's the boidolavus gag, which separates the tongue. We can see the glossopharyngeal nerve here coming in and gives, on average, 3 branches, which penetrate this stellar diaphragm and give innervation to the posterior 1/3 of the tongue. So one of the key areas to remember is that the staloglossus, stylopharyngeus, and the glossopharyngeal nerve will be encountered roughly in the same area. If you encounter branches of the glossopharyngeal nerve, the lingual artery and the external carotid system will be not that far from it, about a centimeter anterior and deep. And we're currently doing some more cadaveric dissections to identify this, and we hope to publish those in the not too distant future. And once again, here is the ascending palatine artery. So why is this particularly important? So it's important that we understand this anatomy and pay attention to this anatomy as we have preoperative planning. Dr. De Almeida showed that nice picture of axial CT scan showing a retropharyngeal carotid. The retropharyngeal carotid can be controlled and encountered, but that's not the kind of case that somebody should be tackling without having at least 40, 50, 60 cases under their belt, in my opinion. I think it's also important to recognize that despite having this stylodiaphragm, in this lateral plane, every now and then you'll have a herniation of the external carotid through this diaphragm. So here you can see the external carotid is herniating through this styloglossus and stylopharyngeal muscle plane. Okay, so if it herniates through that stylodiaphragm, you might think, oh, I'm fine, and I'm doing a really nice operation. I see my muscles. I'm just going through this in a nice plane, and you will transect and cut this vessel, and that will be potentially catastrophic in terms of controlling this bleeding transorally. And you see this here as a cartoon view. Similarly, here's another really dangerous variant, this loop of the carotid as it sort of herniates through this diaphragm, and you can see here this really medially placed carotid, which is can be quite challenging. And this is a sort of a case that you don't want to miss and not pay attention to in your preoperative planning. So again, regarding the bleeding issues, and again, this has come up with Orator, this has come up with ECOG 3311, which was presented at ASCO. We'll be presenting it also. Bob Ferris is going to be giving a talk about that at the Society of Robotic Surgery meeting, which will be August 1st and 2nd. I think it's free registration for all. So I encourage anybody that's interested in robotics to attend that conference and see some of the data and a lively, hopefully lively discussion between Anthony Nichols, the PI of Orator, and Bob Ferris, the PI of ECOG 3311, about the pros and cons of what each of those studies showed. Nonetheless, to get back to this point at hand, postoperative bleeding is a devastating complication and one of the major issues that we have had with TORs, of course, and why some people are reluctant to espouse TORs. So here we looked at the Pittsburgh experience after I had a patient with bad bleeding, and we looked at whether or not we could do something to prevent this sort of hemorrhage. And when we looked at all of our patients, graded from minor to major and including severe, we had about a 9.8 or 10% rate of bleeding, which was really quite high in our opinion at the time. Some of these people had a history of radiation. Some of these are salvages. These are everything. This is sort of our overall experience. And Raj Mandal published this back a few years ago. And we looked again, very similar to what Scott did, breaking our data down, but we want to be a little bit more granular. Did you need 40 cases, or could you do this in a shorter period of time? What if you only did 20 or 25 cases? Was that sufficient? And it turns out that yes, we had about 4 out of 25 cases. We had bleeding events. It dropped to 0 in the next 25, probably because we were quite worried and didn't want to have complications. So we were very, very careful. And then again, as we then felt that we got a little bit better, we sort of saw this rebound, and again, sort of petering down to basically a nice asymptote. And when we looked at this again, that the most common time to bleed was somewhere in the 7 to 10 day range, about a week after surgery. And this is why it was so important to be careful that these patients were appropriately managed, because we typically do not keep the patients in the hospital for this period of time. They typically go home before this. So much of this bleeding happened at home. We then looked at the importance of transcervical arterial ligation on the incidence of any bleed or major or severe bleeds. And we looked at that data from Poli et al., which looked at external carotid ligation. And we thought to ourselves, it doesn't necessarily make sense to ligate the external carotid. If you had somebody with a nosebleed, bad epistaxis, we typically would not ligate the external carotid. We would ligate the major vessels going to that, branches off the IMAX, right? Sphenopalatine, et cetera, anterior ethmoids, et cetera. So therefore, we chose to look at patients having, more selective ligation of the lingual and facial vessels as opposed to external carotid. And what we found was there was, in fact, a significant reduction in bleeding in patients who had a vessel ligation. Now, it doesn't go to zero, but it drops down pretty significantly down to about 1%. When we looked at the method of vessel ligation, ECA versus distal vessel ligation, we did find, again, that branch ligation led to a pretty much complete reduction in bleeding, as opposed to people that had just ECA ligation. And so we thought that this was kind of interesting and probably spoke to the fact that end vessel ligation is most important. And I don't want to go into too much, and I don't want to overstep our time. I know we're running a little bit late, but bottom line is that the ability to do this vessel ligation is really important. Raj Mandal, who's now one of my residents, who's now faculty at Johns Hopkins, did some work on this with me and looked at the ability to protect the airway. And what we found was that people who had inability to protect the airway, either due to mental status changes, dementia, et cetera, severe dysphagia or dynaphasia, would have pretty significant complications with severe bleeding. And so for patients with that sort of mental status changes, if you have to operate on them, if you have no other choice, then tracheostomy is probably indicated for those patients. But in general, we do not tracheostomize anybody with TORS surgery. So bleeding and careful knowledge of the anatomy can be used to avoid complications. The postoperative hemorrhage rate in our initial series there was 9%. We have an updated series now coming out. We've done several hundreds of these cases. I think we're up to about 600 or so TORS cases, and we will look forward to presenting that data. And the vessel ligation, I would say at this point, is not maybe helpful, but is helpful in controlling and reducing bleeding in these patients. Finally, just one note, dysphagia can be expected in these patients, but the dysphagia in these patients can be controlled very, very carefully by having them undergo speech pathology evaluations. We've published on this as well. I don't have time to go into that details, but I'm happy to answer questions on that going forward. And I think that with appropriate monitoring and control, the dysphagia and quality of life of these patients can be quite significantly improved. So thank you for your attention. And if you have the opportunity, we'd love to have you come and visit Pittsburgh and see our city when the time is appropriate. I know in this current situation as travel is quite restricted, but thank you for your attention on this topic.
Thank you, Professor Drury. It was a brilliant talk. There are a few questions. I'll go straight to the questions because I know you have the other talk. So Dr. Kaustuv Patel was asking, do you have any experience in managing post-op bleeding with interventional transarterial embolization? And that's the same thing by another participant, Dr. Dixit. He says the same thing, any role of embolization by an interventional radiologist?
Yes, so yes, we do have the ability to manage these cases with interventional angiography. That's absolutely a possibility. Interventional embolization can be done by very, very skilled people. They need to have 3-plane technology, so that's not always available everywhere. If you have a patient with bad bleeding and you do not have the opportunity to return to the OR quickly, then I think interventional radiology or interventional approaches are very appropriate. They should, of course, if they're doing this, do the same thing, do the needful, which is control the distal vessel. They have to cannulate the lingual and facial and not just block off the ECA, because that is the same as ligating the ECA with suture ligature. So if you do that, then you may get actually collateralization. So there's some case reports of this. I don't know if they've been published, but I believe Dave Cognetti at Jefferson had a patient who had bleeding, had ECA ligation, but then contralaterally canalized the lingual and then developed a pseudoaneurysm of the lingual and then ruptured that and bled again. And then he had to go to the theater to actually do a transoral approach to the lingual to find the lingual and the pseudoaneurysm and ligate it with a clip. And then the patient was okay. So again, these are anecdotal reports, these are case reports. I'm not saying that this happens to everybody, but just something to be thoughtful of as you move forward through the embolization. So in general, I'm not opposed to embolization at all. If I don't have the time to go to the theater, then embolization is a good way to go. Otherwise, returning to the operating room is probably an easier way to control this. In my practice now, in our practice now, in fact, we instituted this for ECOG 3311. All patients undergoing TORS should have ligation of the lingual and facial vessels. And with that, the rate of bleeding has been significantly reduced. And if you already ligate those vessels, then the role of interventional radiology decreases significantly because there's already suture ligature on those and they cannot cannulate them anymore. Does that answer I hope that answers the question for everybody.
So you mean, when you say suture ligation, you actually put suture, like not just clips. So you don't put clips of the facial or the lingual, you actually take...
yeah, I ligate, I suture ligate. Now I don't divide, I just put two ties as far distal as I can and another one a little bit closer to it. And I just ligate them with the 3/0 silk ligature. I'm personally just not a big fan of clips because I think that they also make it difficult to sometimes do my radiation oncologists feel that they may interfere with the post-op radiation and the scattering, and they have some theoretical concerns of that. So to appease them, I just use the ligation.
Mr. Dr. Palleri wants to give a quick comment. I'll just try to unmute him.
Can you hear me?
Yeah, I can hear you.
Yeah, apologies, you had to shut me up earlier. I didn't realize my mic was on. Just to come back on the comment about vessel embolization, I get a fair number of patients sent in with recurrences who don't have neck disease in them. So I have to open the neck purely to ligate the neck in that the vessels in that instance. And we set out a protocol for embolizing those patients who do not need neck dissection in that setting prior to TORS. And speaking to interventional radiologists, they get quite worried about this elderly population who need selective embolization. And they've said as part of the trial protocol, if there is more than 70% occlusion anywhere, they would rather not take this patient on. So we need Doppler and so on and so forth before these patients are taken up for embolization. So it's not easy, even in the routine setting, when it's planned. It's in the emergent setting, unless you have really good expertise, as Uma said, it may not be an easy affair.
Okay. I'm just checking for any more questions. Sorry about that. Yep. I think we can go to the next talk. It was good that you showed some anatomy. I did use the pictures from some of your papers in the morning talk too. So it's good to revise because this area is so tightly packed with vital structures. It's better to keep revising the anatomy again and again. So we can go over to your next talk. This will be robotic neck dissection. And please feel free to start. Thanks.
Sure. So again, this title, I guess the talk I'll give here is sort of the US experience or North American experience with this robotic necks, because I know there are several centers in India that are doing this work, as well as, of course, as the centers in Korea. And so I don't want to belabor some of the details. And I think there's a video session also. So I thought I would focus the talk a little bit more generally on concepts of this robotic neck dissection and why it should be important. So clearly the drainage of the jugular digastric nodal basin is very important, and the management of the neck is really, really critical in these patients, which I don't need to educate the group in India, but of course. But just as a brief segue into some of these concepts, and I know this was some of this work that Dr. Choi presented when he gave the Myers lecture at the American Academy meeting about the evolution of neck dissection. This is sort of a very similar concept. So George Crile, of course, popularized the neck dissection in 1906 while he was in Cleveland, and espoused the Halstedian concept of radical en bloc resections. And so here's a patient of Eugene Myers who underwent a radical neck dissection on the right side, and you can see the typical deformity associated with the drop shoulder, the adhesive capsulitis that happens as a consequence of the shoulder being immobile, and the denervation, of course, of the trapezius muscles, not to mention the deformity that accompanies this therapy, especially when followed by irradiation. So the evolution of the neck dissections, of course, have been seen by this group. The radical neck by Crile, the modified radical is described by Boca. Then the selective neck dissections that were popularized by G. Myers and many others, as well as then in the future directions, the super selective neck dissections that were described by K.T. Robbins as when he was just doing his work with intra-arterial chemoperfusion. And then we've moved even further from that to the idea of sentinel node biopsies as a way to guide treatment. And in fact, in the concept of node-negative oral cavity cancers, this idea of a sentinel node biopsy is particularly timely given the seminal work from India and Tata Hospital looking at the role of selective or elective, I should say, neck dissections in improving survival in patients with T1, T2, and 0 oral cavity cancers. And so the question now becomes, can we use even more selective approaches to address this disease? And this is the subject of HN006 NRG trial that's being led by Stephen Lai, which will be accruing shortly to look at sentinel node biopsies in patients with T1, T2 tongue cancers. So the rationale for this sort of de-escalation or de-intensification, I would say, of treatment is that more surgery may not necessarily be better, or more treatment may not necessarily be better. We now acknowledge that radical neck dissection for the N0 neck is unnecessary. I think that most of us would not be performing a radical neck for the N0 neck in the general case. And in fact, many node positive necks can be managed with less than a radical neck dissection. And that data has also been published over the years and seems to be fairly, the data is fairly strong on that, with a 96% control rate, a 4% rate of in-field failures, and a very low rate of out-of-field failures. And we also recognize that selective neck dissections, by preserving the spinal accessory nerve, 11th cranial nerve, internal jugular vein, improve functional outcomes for these patients. And that is now, I think, beyond reproach. So a common procedure, of course, being performed for the removal of occult or known local regional metastasis is a selective neck dissection. Here's a patient of mine who has a very, very acceptable neck scar from a selective neck dissection. You know, he had a level 1, 2, and 3 disease for a small oral cavity tumor. And of course, this is very acceptable and very, very approachable disease. Interestingly, this is his sister-in-law, who unfortunately also has oral cavity cancer, had a tongue cancer. So the guy before had a small cancer of the gingival buccal sulcus. This lady has a tongue cancer. And she saw her brother-in-law with his neck scar. And she said, well, doc, is it possible that I can avoid that? Because she really didn't want to have that same incision. And being a woman, this was her request. And so these operations, of course, can be performed using this retroauricular, modified facelift type of incision, being buried in the retroauricular space. This, of course, was pioneered and pushed forward in Korea. Dr. Go and I talked about this way back in 2011 when I had first met him in Korea about ways to expand the rubric and armamentarium of robotic surgery in this space. And so the idea of doing this was clearly in our minds, and Dr. Ko was innovative and instrumental in actually moving this forward and doing this in people. And so we reported sort of our first North American series of this robotic assisted neck dissections. And we compared this to an open approach. We did this with the Da Vinci SI system. So we started doing these operations somewhere around 2013, 14 timeframe. This actually is a video that Dr. De Almeida helped me to make. Actually, he made this video and when he was in Pittsburgh with us for a short period of time. And this is what the surgery looks like using the SI system. Now with the SI platform, it's a bit more bulky. It's a bit more cumbersome. It's harder to get multiple arms in. So we do a lot of this surgery transorally, trans-cervically with a headlight by identifying 11th nerve. Then we bring the SI robot and we dock it into place. And then we can do this sort of neck dissection. And at that time, we didn't have good cut seal devices. So we had to use the harmonic scalpel. And the harmonic scalpel, which I think is still probably the best way of doing this operation with the SI robot, really takes away from the surgeon the ability to do articulation, to have the articulation from the robotic system, which is so important. Now, I think with increased technical facility with this, some of my colleagues in India probably can do this operation with the SI using other instrumentation like a harmonic, without using the harmonic, maybe using the Maryland bipolar and monopolar scissors, etc. And that may actually work very well. So here you can see a positive node positive disease in the neck, and we're continuing our dissection and using this harmonic to continue the surgery. You can see that the image quality here is not perfect. It's pretty good, but not perfect. And we can get all the way to level 4. In the interest of time, again, I'm going to sort of jump ahead just a little bit and show that the specimens can be removed. At this juncture, we were removing these specimens in levels. So we would do a level 1, then maybe level 2, 3, and then finally the level 4. And there could be some concern about doing it in this way in this area. But nonetheless, I think oncologically, we have very good outcomes, and it will show a little bit of that. So here's a transverse cervical artery down to the level 4 region, the internal jugular vein, 11th cranial nerve, posterior belly, the digastric, which has been preserved. And this is a very nice selective neck dissection on a lady with a small tongue cancer. And so I actually just saw this lady back in my office. It's been 4.5 years since she has had surgery, and she's doing very well without any evidence of failure. Now, in the instance that you do get injury to the jugular vein, for example, you can easily control this. Again, I keep the robotic system docked. I don't remove the robotic platform to do this, because you can actually use the Maryland almost as a vascular clamp or artery forceps. You can control the bleeding by putting this forceps, and then you can apply general suture ligatures cervically with a lock, and you can actually control the vessel, and you can suture ligate any small injuries that you might have on the jugular vein, just as you would normally. And if you have a small branch that is bleeding, here's another small branch of a vein that was bleeding, you can hold it again with the clamp and then apply a couple of clip forceps, and you're fine. So again, there's been this evolution. So these are some slides that were generously given to me by Dr. Ko. So this is his videos on retroauricular approach with the Da Vinci SI, Da Vinci XI, which is now I would say one of the more commonly used robotic platforms. I don't know if the single port has been launched yet in India or not. I look forward to hearing and seeing videos and information on that. We have not adopted the single port yet at the University of Pittsburgh, mostly because the XI platform is much more usable for multiple specialties, and the single port has not really been granted approval in many of the other specialties that would be using the robotic platform. And of course, as we go forward, you will see that these technologies will continue to evolve, and single port will be coming forward in the very near future. So this is a view of the patient turn 180 degrees. The nice thing with the XI, which is now what I use for these operations, is that this boom allows for much easier docking because the boom can rotate, as you guys all know, and then you can use forearms in order to get great visualization. So this is a brief video of us sort of docking the robot, the docking time, and the placement of this video, placement of the robot is shown here in this video, has significantly reduced our preparatory time for doing these procedures. And we can now do these procedures much more quickly. Sorry. Now we have the forearms of the robot can now be placed in through the cervical incision. And so now we have, I think this is a brief video here showing a level 1 dissection with the XI robot. We can identify the marginal branch of the facial nerve under great visualization and clarity, and we can then use the monopolar scissor. We can see here we're scraping the mandible, so we can now make sure that we're getting all of the nodal tissue in the pre and post vascular space from the lingual and facial vessels, the pre and post vascular nodes, and make sure that these are all taken care of in the submandibular and sublingual space for tongue cancers. And here you can get a really beautiful visualization. So I'm not going to belabor this point, but we've actually created a training platform. So now we train our fellows and surgeons on how to do this much more consistently. We have sort of step-by-step algorithms of phase 1, phase 2, phase 3, in order for them to get a better facility at doing this. And of course, being very good at tours is really helpful in knowing the robotic platform, but this is a different operation. You have to understand how to use the robotic system in a different way. You have 2 energy sources. You have to be able to control that. You have to be able to control how your assistant works in this confined space. And so there is some additional knowledge to be had in this area before people tackle this. So just to be careful of that is really, really important. So in our updated series, I think this number is a little old. This is from about a year ago. So we have more cases than this. We've had no major complications. 1 case of return to the OR for postoperative bleeding. This patient went back to the operating room twice, likely because of some bleeding diathesis that we did not notice at the very first shot, but he in fact subsequently was worked up and found to have a bleeding disorder, which was able to be fixed. So no major complications of bleeding or seroma from this. We do have some minor wound breakdown issues from the post-auricular incision, none of which are devastating, but we do have some of that. And the operative time definitely is longer. I would say now it's about 1.5x as opposed to 2 times longer as we've gotten faster and had our residents and fellows get faster at being able to do this operation. So here's a patient that I just saw in my office on Thursday. He had his robotic neck dissection with me 2 weeks ago. Now, what I wanted to point out is that this is a chap, and you can see from his neck, he's quite scarred. This is a person who had a salvage neck dissection. So I did a robotic salvage neck. I find that this approach is really, really nice for the patients with salvage neck dissections. And the reason for that is that the lymphedema seems to be significantly less when you use a robotic approach versus a transcervical approach. And we're currently studying this, and we hope to have some data to present on this in the near future. And anecdotally, we have found also that these patients tend to have much less dysphagia. So I've noticed, what my colleagues probably have also, I opened this up for discussion at the end, that doing a simple salvage neck dissection on these patients can actually create unexpected dysphagia in these patients. Without cranial nerve injury, without any other neuropathy, just the fact that we do a robotic neck on top of having a radiation or chemoradiation tends to cause dysphagia. Whereas in my anecdotal series of recent patients, they have not had this. And so we're looking forward to studying this in a prospective fashion. And maybe this is an area of potential collaboration in a multi-institutional and multidisciplinary fashion. I think this may be really, really nice. So again, one of the unseen benefits of this in my practice was that having been able to do this approach with the robotics, I was then able to see the extent of operations that could be done through this transrectoauricular approach. And here is a young boy, he's 7 years old, who has a tumor here of the parotid. This was a salivary gland malignancy. This was a analog, mammary analog secretory carcinoma, now known as the secretory carcinoma of the parotid. And I was able to actually do his neck dissection and remove the parotid gland, remove lymph nodes in his neck, not with a robot. This was done actually with a traditional headlight. He is now 5 years out from surgery and is doing very well. He had no lymph nodes positive. We were able to remove 51 lymph nodes in his neck, all of which were negative, and do a parotidectomy on him at the same time. And he's grown up quite nicely. He was, I believe, 9 years old when I met him, and now he's 14 and just doing spectacularly. So these robotic approaches really change our thought process. I think we should use this technique not as saying, oh, we can do a robot. This is not great. Okay, we can do a robot. It's wonderful. But that doesn't really change the care that we're giving these patients, right? We should be using these techniques as a way to enhance our own knowledge base and keep thinking, how can I do these operations in the best way possible for our patients? What can we learn from these operations, and what can we learn from these different techniques to improve not just the simple robotic operation or the simple act of doing the procedure, but to really think from this. And as we move into this next generation of having, single SI, XI, and now single port. And again, this is beautiful data, a slide from Dr. Ko at Severance Hospital, who's been working on this in the recent past. I think we're going to see more and more information, more and more data coming out, and the single port will probably help us in terms of a technique. But I think somebody raised this very interesting question recently about new platforms and using narrowband imaging to improve outcomes of margin control for our patients. I hope then in the near future, and we hope to see this at the SRS meeting, where we will have 8 or 9 companies presenting their new robotic platforms, both in soft tissue and bony. Some may be useful for head and neck. Some are general robotic systems. But many companies are now thinking about not just having a different robot. Like here's the Med Robotics Flex robot that was a flexible robotic platform with 2 eyes for 3D vision, etc. It was nice, but it was still using a cautery and using a grasper. It's still doing the same kind of operation, whether you do it with a smaller one or a bigger one. Effectively, it's the same basic technique. It didn't really change how we do the surgeries for these patients. But here, for example, is a brief video. Pardon the grainy nature, I couldn't find the high-res video of this, but here's a patient, a young lady that had a huge branchial cleft cyst. This was a benign cyst. And again, we did the retroauricular incision, retroauricular approach. And I'm just going to skip through this quickly. We were able to put this retroauricular approach, bring the robotic platform, this was the Flex robotic platform, and do the surgery. And I did it with the Flex because I didn't have access to the Da Vinci robot that day. I was not available for this. So I was able to do the same kind of operation and do the same approach with this technology. So therefore, the flexible technology like the single port may be just as good for doing these operations or even better. Right? It may be wonderful. But at the end of the day, we still did the same kind of technique, which was do surgery, do a cautery, find the glands and nerves and so on and so forth. And I'm just going to skip through this, and you can see that the procedure was performed, and that we were then able to deliver this mass out into the neck. And we were able to show at the end of it that we found the 11th nerve, and we put everything back together. This lady was also African-American. She had a very dark skin. And so she didn't want a keloid. She was a potential keloid patient. So we were able to do the surgery there without having it expose the neck. And here was a benign pathology, and everything went really well. So that was really, really nice for that particular lady. And those of you that were on the prior Zoom talk that I did to the subcontinent may remember this data, but I want to show briefly some of the new technology that I think might be very interesting that's coming forward. And this is using not just NBI, which in my opinion has some value, but has not really been able to be espoused completely because it hasn't really proven great value in NBI, Yes, you can see some defects, but it's not really clear. One of the things that I think is really, really interesting going forward is newer ways of imaging. not just NBI, but other spectroscopies. There is, laser Doppler spectroscopy. There is, iKnife that Dr. Polari is working on, and recently published, I believe, in Cell, or one of those high-profile journals, showing that you can detect the margins by using this iKnife and mass spectrometry. Very, very exciting things. And here, as a homage to Subcontinent, I couldn't pass up the opportunity to talk about one of the Nobel laureates from India, Professor C.V. Raman. As we know, Subhash Chandra Bose also won the Nobel, not to mention Professor Sen in economics, but C.V. Raman won the Nobel in physics in 1930 for a description of a technique that he noticed, which was called Raman scattering. So when you hit a particular object, whether it's organic or inorganic, with laser light, very, very weak signal can be observed. Only one out of 10 million 10 million photons will backscatter. And this backscattering is called the Raman scattering. And this Raman scattering happens because of the composition of the material that is being struck with the laser. So the Raman spectroscopy is used to assess organic molecules, and you guys might remember this from studies of organic chemistry and chemistry studies in your A levels or 10+2. But Raman spectroscopy is now coming into the foray, because we can now use this to study biological components and not just the organic nature of small molecules. So we have done a small study, which is currently in preparation for publication, by my colleague, Dr. Shyam Sridharan, who is one of my younger partners who's working on this. So we looked at tissues from a tissue array that we had collected of oral cavity tumors. The majority of these were oral cavity tumors, where the patients underwent surgery. And we wanted to see, could you tell which oral cavity tumor was going to be metastatic to the neck or which one wasn't, based on the biological characteristics of the Raman scattering? So again, hearkening back to the data from Tata's, yes, we know that elective neck dissection is important to save lives in people with oral cavity cancer. But what if you could tell which patients had biologically different disease? Wouldn't it be cool if you could say to this particular patient, you have disease that requires a neck dissection, but you have disease that does not require neck dissection because you have fundamentally different biology? So that, I think, would be the great advance. So we should be looking to this. Again, this is a very small study. It's only 23 patients in each group. I would not base this as the way to start changing care for our patients. I'm not saying that at all. But if we could start looking at studies like this and do Raman spectroscopy in vivo or iKnife in vivo or some way to study this in vivo, then the ability to do these cool robotics surgeries become more useful. They become more valuable. In fact, what we found in this particular study was, although this was a very heterogeneous group of patients, anywhere from T1 to T4, with subsites of oral cavity and larynx, and some oropharynx as well, but most of them were oral cavity and larynx, we found that you could have a fantastic ROC curve, and we could have tremendous sensitivity and specificity of looking at which patients were able to be metastatic versus non-metastatic. And so I think that in the future, this sort of work might be able to distinguish the biological characteristics of the patients. And this is where I think robotics and robotic surgery should be going in the near future, is to synergize with this technology to improve data. So robotics systems will now no longer just be flexible cautery or flexible laser or straight laser or three arms or 4 arms. They should really be data collection systems that will fundamentally change how we do these operations. And this is one of my first patients that I did this on. This was when Trimming Lim was my fellow, who's now very famous senior surgeon in Singapore, who is at the National University Hospital System there, very, very famous. So when Trimming was my fellow, we operated on this young lady who was 24 years at the time with a high-grade mucoepidermal carcinoma of the parotid. She underwent a paroidectomy and a modified neck dissection through this incision. She is now, oh my gosh, almost 8 years out from surgery, free of disease, and has done very, very well. And we did this with what we used to call the old robots, which were our registrars and our residents who would hold the retractors for us. They were like the actual, manual robots of the day. Now we have cool computerized robots, but the idea that robotics is necessary to do this operation is not what I'm espousing. This technique can be performed with or without robotics, but the real advantage will come as we see the next generation of robots to establish follow-up for the patient so that we can appropriately select this young lady for this operation, as opposed to the countless other people with high-grade mucopelvic carcinomas that were also T3 and 1 who end up having metastases and recurrences and having bad outcomes. So why did she do well, but other people not do well? That is, I think, truly the next frontier, which I hope that everybody will espouse to going forward. So I'd like to thank many of my registrars and residents who did a lot of this, the hard work in putting this all together. And thank you again for your attention. Oh, there was some other slides there. I'm going to end here. I'm happy to answer questions. I think I saw some questions popping up here on the chat.
Thank you, Dr. Roy. It's an excellent talk. I'll go straight to the questions. So Anand Subhash says that, was asking, do you use the robot only for level 1 or for the entire neck dissection? We have found using the robot only for level 1 and level 4 was faster.
Yes, it is definitely faster. Using the robot for level 1, level 4 is faster. You can do level 2, 3 definitely just with the headlight. So now with the XI, what I do is I lift the flaps, I sort of identify and see the nerves because I can see them with the tactic feedback. I'm worried again of accidentally pinching or hurting something. So I see the marginal branch of the facial nerve, as you saw in that level 1. I find the 11th nerve. I go inferiorly and I mobilize some of the rootlets, and I bring the robot in and I sort of complete off the dissection there. Again, now I do the specimens in one piece. I try not to do compartmental dissections.
And Anand asks 2 more questions. I'll just finish up with Anand. The subplatysmal flap elevation is elevated and fixed using rigid retractor. And creates a triangulation distally, reducing the space. Any tips to overcome this? I think further, the edge of the retractor, there's a triangulation over there. The space gets narrowed.
Yes, the space does get narrowed. So there are a couple of things. Number one, I'm designing my own retractor sort of handles, because the ones that we have were actually designed for the thyroid. So I was doing transaxial thyroidectomies 10 years ago. And so at that time, much longer handles were needed. For the neck, it's a much shorter space. Yeah. So a weight on the end of the retractor will actually lift will cantilever the retractor slightly and give you a better space, working space, number one. Number two, I think Dr. Ko may have his own set of retractor arms, et cetera, that he's developing in Korea. Unfortunately, we don't have access to those here in the US, so we've had to kind of do this myself. But you can also, there also is a slight different shape change. So it's opened more, so it lifts the flap a little bit in a broader front for the surgery. Again, we are sort of using what was designed for thyroids to do the neck. The thyroid, you're focusing on a very small area. So the whole setup was a little bit different.
I think if you're designing retractors, you can put the concepts of origami into it. That kind of helps maybe.
Yes, exactly. In fact, Neil Godze, who's one of my residents now, is an origami specialist. And so he actually has been helping me with that. So you're actually quite right on the money.
Okay, great. So then the other question from Anand is, details of docking when using the 4th arm. 2 of them would come on the same side.
Yes, so 2 of them do come on the same side. So really, in terms of the details, I didn't go into too much of the details because it was a video session. I didn't want to be redundant. But effectively, what you want is a triangle shape. So I like the camera at the top, and then I like a triangle shape. So on one arm will be the cutting, one arm will be the grasping. And then the second, so that's 2 arms. The 4th or 3rd, depending which way you want to look at it, because the camera is technically 1 arm, will be the retractor. So I use a retractor, which is on the same side as the arm that I use as my forceps. So I use a Maryland bipolar as my forceps and monopolar scissors as my cautery/scissor. So I can do the dissection of the nerves without having to use energy. So yes, 2 will have to be on the same side. And this is what requires a little bit of expertise and actually some guidance, because again, if you should learn from the mistakes of those that have come before and have sort of fought some of these fights to not have to have that
I think
the challenges.
The last question from Anand is, any thoughts on transcontinental remote surgery being a reality? The idea started that way. Yeah.
Yes, absolutely. So this is going to be one of the topics at the SRS meeting. We will be having a talk from Jacques Marescot, who did the Lindbergh operation, which was a transcontinental cholecystectomy with a patient in France, Strasbourg, being operated on by a surgeon in North America, in New York. I think that the idea of bandwidth had been a big problem for a while. 5G is going to change that. We will have much better bandwidth. People are doing some 5G surgeries in the country. We have already started doing remote proctoring with a telementoring cart that we've designed at the University of Pittsburgh within our hospital network. We own 43 hospitals. One of them is about 4 hours driving from us. So those patients cannot always come to us. So we've already started doing remote proctoring of robotic surgery. It's really been for gynecology. But I think that this is on the way to reality. It's not, pie in the sky anymore. It's here. It will be here.
And Dr. Nagarjuna Reddy says, what retractor you're using for retraction of the skin flap?
So currently, I'm still using the same retractor that's used by the Korean group, the one that's used by Dr. Go or his mentor, Dr. Chung. So that's, I think it's called the Chung's retractor. And this was the one that was originally designed for transaxillary thyroidectomies. Mm-hmm. But we're modifying some of the blades on it to make them a little bit shorter and a little bit heartier. Those also are designed, I think, for the Asian population. Most of those patients were very sort of young, thin women. Unfortunately, my patients tend to be a bit more robust.
High BMI.
Higher BMI, a bit bigger personality. So we need more weight. Otherwise, the arm cantilevers and bends, and then you get that triangle being formed, and then you don't have good space to do the dissection at the end.
Got it. And Dr. Gopal Kumar, I think Gopal just came from Korea. He's asking, comment on neurological or non-neurological complications in robotic neck dissection versus open technique.
Yeah, so excellent question. So we have not, so again, complication-wise, I've looked at bleeding. I think bleeding is comparable between open and robotic neck. We have looked at seroma formation, again, comparable. We've published on the drain outputs of patients with robotic versus open neck dissections. The drain outputs, et cetera, are the same. The length of time that the drain stays in is the same. I believe that there is an advantage from lymphedema perspective, because although you're removing the lymphatics, the fact that you're also cutting the skin in a transverse incision means that you're cutting the lymphatic drainage from the superior to the inferior direction in the skin flap. By making a retroauricular incision, you're actually allowing the drains to go. And I think you can intuitively almost perceive this when you think about patients that have a visor incision right across the neck versus those that have maybe only one-sided neck incision for an operation. They have less lymphedema. Right? When we do this, in fact, for supraglottic cancers, I now do 2 incisions with a skin of bridge connecting the superior to inferior, and those patients have a lot less lymphedema than those that have a transverse incision for bilateral neck dissections. So I think it's intuitively obvious that this would help, but we do need to study it and see what the magnitude of the effect is, and is it worth it?
No, you're right. Sorry.
I'm sorry, go ahead.
No, you're right, because people with dysphagia post-radiation also, they have a lot of lymphedema, and that could be the link which you're mentioning, retroauricular, lesser dysphagia than horizontal neck incision in a salvage setting.
Yes, exactly. And so especially in salvage setting, when we know that the lymphatics have already been disrupted by radiation, right? The primary lymphatic drainage has been disrupted. So the body has adapted to drain through the skin. Now you come and you cut the skin and you destroy those lymphatics too. So then you make it sort of doubly worse, in my opinion. So I think it makes a lot more sense to not have it be, to not have to do that. So we're studying this. From a neurological complication, I will tell you that I have seen more marginal nerve praxis from the robotic neck than the open. I don't know if that's because of the technique that I'm doing of the cautery close to that area, or maybe because when you come with this angle, one of the arms has to come close to the angle of the mandible. I wonder if it presses on the marginal nerve without knowing it. I even had one patient wake up with a robotic thyroidectomy with the marginal nerve praxis. So I can only imagine that must have been because without recognizing it, there must have been some compression of that nerve without realizing it. So just something to be careful of. But again, I think we're still in the early learning phases of this. The Koreans have a tremendous experience. The rest of us have a slightly lower learning curve, so we're still catching up to us.
And Dr. Jagannath says, what's the adequate length of a post-auricular incision for adequate exposure for completing the neck dissection?
So we've measured that. Typically, it's 5 to 6 centimeters, including the retroauricular portion and then the hairline incision portion. So I'm just going to go to the slides here for a quick second and show you. So this chap, can you guys see that? Can you guys still see my screen?
Yeah.
Yeah. So this chap had a level 2-3 dissection because he was irradiated before. And so I didn't do a complete 1, 2, 3, 4 on him. But you can see through this relatively small incision, I was able to do the entire 2-3 neck dissection from the digastric to the omo. So if you want to go more inferior to level 4, then you have to extend the incision. If you want to go more anterior to level 1, you have to extend the incision. And so again, for this chap, I didn't do this approach because he was afraid of a scar in the neck. He has no hair. This is going to be visible, just like a neck incision will be visible, but he really has no lymphedema. It really is from a functional perspective that I like this approach. Similarly, I think I had another lady here who had a level 1, 2, 3, 4, and she had a quite nice approach here. This is about 6 centimeters, and she had a 1, 2, 3, 4 complete dissection, virgin tumor, primary tumor.
Thank you. And Dr. Kaustubh Patel says, don't you think that this kind of neck dissection, 2A, 2B, 3, and 1B can be done manually, faster with good retraction, and for level 1A and maybe 4, you need the robot? I think it's
I don't disagree. Again, I do not. This is why I wanted to sort of give a more of a balanced talk, I would say, by showing this patient. I was able to do this entire operation without a robot. I did not do level 1. I was able to actually get to level 4 in this young boy because he was the skin is quite flexible and you can get there. So I don't think a robot is needed to do this operation. You don't have to use a robot to do this operation. I do think that the robot can help. And again, as Dr. Patel says, yes, a long cautery handle is needed. Slender instruments are needed. You probably need a very long forceps like they use for gynecologic pelvic surgery or for thoracic surgery, for example. Longer instruments would be helpful. And I don't really think that you have to have the robot to do this. I do think the robot helps in some situations. The post-radiation neck might be helpful. The ability to have powered instrumentation in the robot might be helpful for this. What I'm really looking forward to is the development of newer robots that can be influenced by our surgeons to provide actual value to the patients. Understand imagine a world where you could see if a node had extracapsular extension even before you are finished with the operation. So you could do a more comprehensive resection of that node and take it out just by shining some light or doing something, an eye knife, whatever it is. That would be things that would change how we deal with these patients, not just doing a robot because we can go from this way versus this way. In my real opinion, I think that's really the benefit of this.
One last question is by Dr. Akshat Malik. He says, any advantage of using free flaps to cover radical tonsillectomy defects in terms of swallowing and bleeding? I think this is for the complication talk.
Yes, I think that there is. I think that there is a benefit to covering these defects when you are really worried. So I think that using a flap to cover a radical resection, and I would ask everyone to remember, and this is one of my pet peeves, I don't like calling these radical tonsillectomies because it gives it the impression that you're not doing a true sort of oncological operation. Right? These people are having an oncological cancer resection. It's an oropharyngectomy. You're removing the lateral oropharynx from these patients. So if you do a radical resection, a lateral oropharyngectomy on these patients, then I think that in terms of bleeding, definitely, yes, it will be less if it was covered versus open. But then you have to ask yourself the question, what is the value of doing a free flap on these patients? Now, if they have failure, if they're salvage cases, if they're cases, as Dr. Paleri and Dr. De Almeida said, where these wounds are not going to heal well, then absolutely I agree that I think a reconstruction flap in those patients will help them. In the virgin case where you're doing an operation for somebody that doesn't have this much complication likelihood of healing is better, then I think the bleeding risk is, number one, going to be very low by ligating the vessels. And number two, the idea of doing this, of getting better swallowing in these patients by doing a flap versus not, is interesting, but we need data to think about that. I think that the likelihood of having swallowing difficulties will happen more because of giving irradiation than because of the surgery.
Thank you, Dr. Uri. These are the questions we've done. We'll go to the next talk. That's by surgical video by Dr. Mudit Agarwal. Dr. Mudit Agarwal, thank you for being patiently waiting. And he's been very active in all the discussions, in the initial discussions, but now it's time for him to take the podium on the Zoom. So you'll be talking on surgical, on modified BABA approach for paratracheal lymph node dissection. Thank you, Dr. Dubey.
Yeah. Thank you.
Thank you, Vidya. It's been really a pleasure to listen to all these great people. And I'm a great fan of trans-axillary, retroauricular approach. And I've been doing this for most of my cases till now. But I found some problems with the retroauricular, like if you're doing a thyroidectomy, then the problem, what it is there, is that contralateral side, I'm not able to address if I'm doing a total thyroidectomy. So if I find that if like Dr. Ko is great experience in doing a contralateral lobectomy also from the same side, but I don't find that I am so much confident in doing, so I prefer giving another incision if I have to do a retroauricular approach. So I was thinking of doing something. So one patient had come and I will show you that we modified and we wanted to enter into another field, another technique of how do we obviate these problems. And as Dr. Uma has already said, that assistant is really troubled while doing a retroauricular because they have to bend, retract, all these things are there. But if we do this technique, I think assistant are at a little bit peace as compared to retroauricular. So I will show you. This was one of a patient, 35-year-old female with left thyroid nodule, papillary cancer, and ultrasound neck was done. Which showed, and a CT scan as well was done, and which was nodule of size 3.5 into 3 centimeter with paratracheal node of 2.5 into 2 centimeter. Rest no lateral compartment nodes were there, and contralateral central compartment was also clear. So this is the CT scan. You can see a nodule, the nodule of the thyroid, and when you go down, this is the paratracheal node of around 2.5 into 2 centimeter. So you can see this is the position which we adopted. It is not a standard BABA position, but the extended neck is there. So extended neck helps the node which is near the suprasternal notch to come out. So that's why we opted for this positioning, so that it will be easier for us to remove that paratracheal node. And 4 ports are used traditionally as in BABA, but we had used one assistant port for accessing, for putting clips as we do a central compartment clearance for this lady. And you see this band is also put near the breast, lower border of the breast to elevate them. I'll explain to you. So what it does, you can see the nipple height. This is this is picture taken from Professor Kim's from Seoul. What he did was to increase the height of the nipple. He put a band, elastic band here, so that the height of the nipple increases, and the pivot point it also goes down like this. You can see now your instruments are placing like that, and the blind spot which you get in this area is obviated. So similar technique which we followed here, and we have used the exercise system. And what we have done, we have not given any incision for the assistant port. We have used a laparoscopic instrument like a hook and suction and a camera which we have used, and to create the flaps so that docking of the instruments can be done after creating the flap, and we can reduce the dissection by the robotic arms. So traditionally, how we do it is the same thyroidectomy. We do it centrally. You split the straps, and then we go to, you can see the thyroid lobe and a paratracheal node here. So it's a large paratracheal node here, 2.5 centimeter. So same steps are followed, like middle thyroid vein was taken, clamped. Then we had gone in between the node and the thyroid to find the recurrent angial nerve here. So recurrent angial nerve could be identified, and after that, so we have to take care, and then we proceeded for isthmectomy, because we can't remove whole of the specimen and block it. It will be difficult to handle it. So we did isthmectomy, and then we were just on the recurrent angial nerve and pressing it up. The whole of the recurrent angial nerve was traced up, and then coming to the upper pole, you can see that we see the external branch of superior angial nerve, which we had saved, and after that, the superior pedicle was ligated. Now coming to the central compartment, the node. So we are going from medial to central approach. We are on the trachea. We are dividing the tissue here. So we take the tissue laterally, and there will be some veins which will be coming from the thymus to this paratracheal area, and which we can use. This assistant arm is used to clip this, or you can use a cautery also. Then this specimen is reflected laterally, and we dissect it while seeing the recurrent angial nerve. So because of the robotic 3D view, I think it is much comfortable as we are viewing presently the 2D view. So you can see the thyroid specimen has already been taken out. It's only the node here which we have to take care. It's a larger node. We can't hold it, otherwise it might burst open. So we have to take care that we don't have to hold at the area. So now you can see this is the thymic tissue. So we just dissect it around. So we have to keep the recurrent angial nerve into view. So recurrent angial nerve is freed from the node all around. So the tissue from the esophagus is also taken up. So we have to remove the nodes medial to it and lateral to the recurrent angial nerve. So these tissue which we take, we count it and park it so that we don't miss out there when we are removing the specimen. So this side we have not looked into the parathyroid because much tumor burden is there. And here level 4 we are dissecting. Now we have come onto the left common carotid area. We are dissecting the common carotid here. So whole of the tissue in the central compartment has been taken over. So we have divided this paratracheal node and kept it up because specimen was really big to handle. So this nodal tissue, you can see the lymphatics there. So what we do, this is thoracic duct lymphatics which were there. So we had put a hemolock clip below it. And this nodal tissue which was remaining was also removed. So now coming on the contralateral side, so I'm not going to the full steps of thyroidectomy, it is same. So on the right side, you do the similar procedure, identify the recurrent and ligate the inferior thyroid, and parathyroid, inferior parathyroid is preserved. And superior one, we go close to the superior thyroid, and then we preserve the supply. And you can see here, the ligament of Berry is being dissected on the right side, and the specimen is removed. So now we have to do the same thing, remove the tissue medial and lateral to the recurrent anginal nerve. So you can see the parathyroid gland here. So morning we heard about the nerve monitoring technology which can be used, but I tried to, but the NIM person didn't have that robotic. They didn't have the idea of how to do it. So this is the post-op. You can see the post-op after 2 weeks, the fiber optic laryngoscopy picture. Bilateral vocal cords are mobile. Patient didn't have any problem. And the post-op problem which patient had was hypocalcemia, which was managed conservatively. And patient did have minimal chyle leak around 50 ml, which was done with diet modification and injection somatostatin. And patient was discharged on the 5th day. The TG levels which we did at 4 weeks was 0.06. And then after that, patient was, and 50 nodes were dissected in the central compartment, of which 3 were positive. And opposite contralateral lobe had also had a smaller tumor. So patient was a candidate for radioiodine therapy. And before doing a therapy, they do a radioiodine scan. You can see right side small uptake was there. Rest left side was totally clear. So I thank my surgical team for being with me, and I hope everybody is safe.
Thank you, Mudit sir. It was a wonderful video. It's great that you're thinking laterally, and this is truly a minimally invasive surgery. I saw very little blood loss. It's a truly minimally invasive, and it's good that you're taking Baba to next step further. There is one question from Anand who say, do you use the drain post-operatively?
Yes, we had used a drain. We had put the drain to the axillary port, and we use usually this JP drain, Jackson Pratt drain we put. And we use some fibrillar also for hemostasis because extensive dissection was done. And there was some oozing which have been edited. We have not seen in this video, but on the left side was there. So we had put some fibrillar agent also on the left side.
But the field is nice, and you can see all the yellow.
Yes. You can see the approach which you do it like this. I think because of extension, the thyroid tissue comes up. And when you do retroauricular, the neck is not flexed, so you have to go deep down in the cave and you have to dissect it out. And especially for right-handed surgeon, doing a left-sided thyroidectomy is relatively challenging when you're doing a retroauricular approach. So, and oppositely, if you do it in this Baba approach, for a left side, it is a very good approach. And right side, you have to change the ports also.
So customization is key.
Yes. So you have to choose if you know the techniques, you can choose it according to the patient.
Thank you, sir. Thank you very much. Anyone has any other questions to add before we get a feedback from our faculty for this session? If it's if no other questions, would the faculty for today's session, Dr. Dabas, Dr. Mudit Agarwal, Dr. Duveri, can you give us feedback about the session for today? And it has been like a HCG tradition. I think they get their last comments from all the speakers after every webinar. So I'll start with you, Dr. Agarwal.
Yeah, I think though this meeting has been really wonderful. We were missing out these meetings because robotic, we have a small group and we tend to keep on meeting in Korea, in other places, but we were not able to do it. And meeting all the great persons, we have not, Dr. Almeida, I have never heard of him, but I could hear him here. So it was nice to be with all. And we met most of them in the BAS conference. But it's great to have this kind of platform, and it's really hats off to SCG Group for doing this. Yeah.
Dr. Dewey?
Yes, thank you so much to everybody for staying on to the very end. It was a very, very nice session with wonderful comments, and I think very, very thoughtful questions, and raising some opportunities for further interaction. And I would say the one comment that I would leave with is to follow up on what Dr. Dabas had sort of talked about, right, which is the trials. India has such a tremendous, unfortunately, a tremendous number of patients with cancer, which nobody wants to have, but it is what it is, that there's an opportunity to do trials that can be done in India, which we cannot accomplish, I would say, almost anywhere else in the world. And so the ability to push that forward, I would encourage all of the tremendous surgeons in India to rally in a cooperative sense to submit these trials, to move this forward, because then you'll be able to provide data which the rest of the world would take years to accomplish, if not a decade. You will be able to do in, unfortunately, a very short period of time. And you've already seen some of that coming forward from the Tata Group, from Amrita Group, and others with the prospective trials that are changing practice throughout the world. So that is a tremendous power and responsibility that I think that the Indian surgeons have. And I would encourage you to continue to work on that. And I think that that's wonderful. So thank you.
Dr. Dabas?
Hi, Vidya. And I will say Dr. Vishal Rao is, I know, is a mentor to Dr. Akshay right now, and he must have a plan to do a robotic meet. But you and Akshay has been instrumental in just bringing all robotic surgeons for this meet. And I would say Akshay was not well, but still he managed to do that. I was in very personal touch with him. And bringing all people together and sharing their experience in robotic surgery, yes, it's a superb job. And everybody is expert, is speaking about when to do it, when not to do it, complications, indications. So for the beginners, yeah, we are telling them that Scott has told them about how we start with this. So we have covered each part of TORS in this meet. And hopefully once this pandemic is over, let's have a good meet. We're all together, and we are hopeful we should have a very good trial in India because we have a lot of patients. And let's bring with data. I have just requested Uma also. He may support us technically. Even Scott can help us in that. And we'll bring together a very good data.
Definitely.
Finally, I think, thank you, Vidya. I mean, you have been very instrumental in organizing this, helping us with our team in HCG Bangalore. And thank all the international delegates, especially Professor Dewey and rest of them who were participating, and Professor Paleri, who chipped in with some good discussion. And of course, our Dabas sir, Mudit Agarwal sir, and Rajesh sir, who participated in. Thank you. Looking forward. Thank you, Vidya, again. Looking forward to see you everyone next Sunday between 10 to 12:30, and then followed by the evening session between 6 to 8:30 p.m. For now, I think it's a good night from India. Looking forward to see you next weekend.
Right.
And, Thank you. Thank you all my colleagues and my senior colleagues, and also Dr. Kaustubh Patel and the other senior colleagues who've been online for almost quite a long time. I know we overshot the time, but right now we have almost 25 to 30 participants. So it's great that they have so much interest in India. So thank you very much.
Yeah, of course.
Thank you, Vidya.
Yeah, Kaustubh sir was really very supportive. He stayed right through the meeting. Looking forward to see sir next weekend as well. Thank you very much.
I have a small request to Uma, if I can be allowed. Yeah,
sure.
Uma. Yeah, Uma, we would like you to guide us for funding. To start these kind of multi-institutional trial, we need funding also. And we will get in touch with you how to get funding for these trials. That is also a very important aspect of running trials.
Yeah, no, it's a very important aspect. I don't know if you can see, but I'm in my office right now. I'm working on a grant to write a prospective trial for induction therapy followed by maintenance immunotherapy for oropharyngeal cancer. So these things take a lot of money. They take a lot of effort. It is not simple. You know, we talk about trials as though it's there. In fact, I would suggest this maybe to the organizers of future meetings, that you have, now that you can do many of these things by Zoom, have somebody that has done trials to talk about what is required to do trials from a scientific perspective, from just the general concept, and also what's required to do it in India. I mean, I don't know what it takes to accomplish a clinical trial in India. I'm sure it must be, if every country has its own set of challenges, regulatory challenges, funding challenges, etc. At the end of the day, I think that there is actually great opportunity to write grants. We actually just wrote one with somebody in India from the National Institutes of Health to get funded. And in fact, Tata's has some funding with the University of Minnesota looking at tobacco cessation. So there are many opportunities, and I think there is opportunity to have funding that can be done, especially if you can show that the disease data from that disease site will be applicable to the whole world, which this clearly is. HPV negative disease is a very common disease. Doing this will be very, very helpful. So the short answer to your question is yes. The long answer is we should also rally and make sure that this is done to be of best interest and best thought for the Indian community, because what we do in the US may not be what's directly applicable to India, just like clinical care.
Thank you.
In fact, Vin, are you still, if you're on, maybe you can give a comment. I don't know if Professor Paleri is on or not, but he's a world's expert in of course, running trials and doing this. And he's been so successful at it. I don't know if he has any comment.
I think he's been unmuted.
Yes, I'm on. Valid point. I have had similar discussions with colleagues in India, and it takes a lot of practice. It takes a lot of thought. You need to be guided to write a compelling grant application. And I think we almost need to hold a grant writing workshop to get your head around how to craft a simple, answerable research question that can be robustly performed in a trial setting. And apart from starting from scratch and setting up a whole study day for this, there's no better way to teach people.
So Professor Paleri, Akshay here. So me and Vidya will write to you and probably plan a meeting with regards to probably a research and grant and conduct one meeting similar on grant writing probably, if you're okay.
Yes, definitely. I'd be very happy to help out and advise with Uma and other people. So
perfect.
Be delighted.
Perfect. Thank you.
Thank you.
I think thanks Vidya. Thanks everyone, Kaustubh sir, and the whole all the participants for participating. Looking forward to see you next weekend, 10 to 12:30 and 6 to 8:30, same time. Until then, bye.
Wonderful conference, wonderful data.
Yeah,
thank you so much.
Well done to the organizers. Really good day. Thank you.